Dibuka tau. Oke, untuk seluruh peserta, persiapan ya, kita akan mulai agenda pada pagi hari ini, seminar hari kedua. Assalamualaikum warahmatullahi wabarakatuh. Concerning to Okmandino, failure will never overtake me if my determination to succeed is strong enough. Ladies and gentlemen, good morning, and welcome back to the last or second day, first international seminar of Asean Wound Healing Science Multidiscipline and workshop of recent development of burn and wound care. So come back with me, Sarah Aulia, to guide you and moderate the last day seminar. So please stay tuned on live Zoom till the end and stay enjoyed, stay focused on the presentation forward. Jangan lupa untuk presentasinya ini juga live di YouTube channelnya kita ya. Jadi bisa yang nggak bisa gabung di Zoom bisa juga gabung di live streaming di channel YouTube. Okay, today coronavirus is continuing spread across the world with more than 56 million confirmed cases in 190 countries, about 1.35 million deaths. Furthermore, to continue this webinar, I'm going to get you a guideline, approximate 3 sub-materials will be explaining by the great speaker later on. Firstly, the DIMES concept 2020. Secondly, management of chronic wound and multidiscipline approach. And the third, infection control protocol and management in wound care part 2. So, but don't worry, there is a question and answer sessions between it. So, ladies and gentlemen, as far as I'm concerned, that the material today is important as the material yesterday that's still around in wound care amid pandemic situation exactly. So we count a little time for starting. Oke, langsung saja saya akan undang pembicara pertama kita pada pagi hari ini ya. Pembicara kita yang pertama berasal dari Filipina. So to all audience, it was the only beginning to so stay tuned. Moving right along, we have the next very special guest star or speaker. Well, the next one speaker is from Philippines. That's right. He's Mr. Ryan Hitala, registered nurse, Magister Science Nursing, wound ostomy continence, certified food care nurse. And some the title from Mr. Ryan curriculum vitae. Mr. Ryan Hitala is interstomal therapist nursing at Makati Hospital in Manila, Philippines. He is professional intravenous therapy nursing. He also certified for infection control from Asean Pacific Society of Infection Control. And Mr. Ryan certified in wound ostomy continence also. So in this time, he will be sharing her best expertise on management of chronic wound multidiscipline approach. So, well, let's invite him to join with us for sharing his best material. So we're so curious about his material today. Okay, so please welcome Mr. Ryan Hitala. Hello, Mr. Hello, Mr. Ryan. Oh, I'm sorry,
Hello.
Mr. Ryan. Okay.
Hello. Yes, hello. Is that okay?
Hello, Mr. Ryan. Okay. How are you today, Mr.? Are you good?
Hello. I'm fine. Thank you very much. And I'm really glad to join you here and participate in your wonderful seminar. And I hope that I can can give you much help and share what we have experienced here in the Philippines.
Okay, we're glad to see you too, Mr. Okay, Mr. Anyway, what time in Philippines now? What time?
Right now it's 9:30 a.m.
Okay, so how about...
It's sunny. We just finished the last devastating typhoon just a few weeks ago. So it's nice to have a good weather now here in the Philippines.
Okay. Okay, Mr. How about the conditions in Philippines right now? Exactly in pandemic situation.
Okay, right now, actually, the cases are getting lower. It's much more controlled, and there is a little cases of critical patients. Most of them
Critical.
just have minimal to medium signs and symptoms, but not really on a critical level. And there are many asymptomatic persons actually
Yes.
who are getting positive results but doesn't have any signs and symptoms. So what we do now is, which I will also share later, is really on how we tend to control those
Yes.
cases and separate people with signs and symptoms from those who doesn't have. And it's just a matter of doing hospital protocols, and also by adapting to this new normal which we are going to experience. And it's really difficult at first, because we all know that change is sometimes difficult to accept, but it is inevitable. And we do hope that I know all of us, including my brothers and sisters there in Indonesia, we will
Oh,
all
really?
pass by this problem.
Okay. Okay, Mister. I want you to say hello to all participants because our participant is majority from Indonesian. So please
Oh, okay.
saying hello, hello Indonesia.
Hello, Indonesia. Selamat
Okay.
pagi.
Selamat pagi. Yes, it's right.
Selamat pagi.
Okay. Okay, Mr. Ryan.
Yeah.
I think enough for introducing. So, Mr. Ryan,
Okay.
time is yours.
Okay. Thank you very much to our dear host. So, this is just a brief biography of mine. So, I finished nursing school last 2000. And currently, I'm a clinic nurse director of the Stomach Complex Wound Care Clinic here at the Medical City Hospital in Philippines. And also, I really have been doing the roads of or in the road of as wound care specialist and ostomy care here in the Philippines, because here in the Philippines it's really rare career opportunity for nurses. So there are only few of us. So the topic that was given to me, assigned to me, was about management of diabetic foot ulcers or injuries during the pandemic, and on the perspective of Philippines experience. Now, when it comes to this, first I would like to define what is diabetic foot ulcer. So, diabetic foot ulcer is basically a non-healing and poorly healing wound. It may be partial thickness or full thickness, may be or should be always be seen on the below ankle of the individual with diabetes. It's a complication of diabetes and can be critical in the natural history of diabetic foot. Now, a foot affected by ulceration that is associated with most of the time or sometimes with neuropathy or other peripheral arterial disease. And in our experience here in the Philippines, most of the time, patients would visit the clinic on the late stage, or when wherein the ulcer or the wound is really difficult to take care or to manage, because at first they really are hesitant to go to the hospital even without the pandemic, because they think that it is just a simple wound. And most of the time when they go to nail spa or nail parlor, that's where they get these ulcerations due to the pedicures or manicures. Now, epidemiology here in the Philippines, diabetes mellitus is ranked 8 to 10 leading causes of mortality here in the Philippines. This is according to our data of the Department of Health. And in the World Health Organization, diabetes affects as much as 347 million people worldwide. And is estimated to affect 380 million people by the year 2025. And in the Philippines, there's about 1 out of 5 Filipinos, no, approximately to 11 million of our population, are about diagnosed to have pre-diabetes or diabetes in combination. So basically, I myself, it's so funny because I myself am a diabetic patient. And for a diabetic patient, the lifetime risk of a person with diabetes developing a foot ulcer may be as high as 25%, whereas the annual incidence of foot ulcers is, of course, 2%. This is according to the American Diabetes Association last 24. Now, when it comes to other complications, we always see that lower limb amputation is one of the most chosen treatment option when considering diabetes foot management. However, nowadays it is not considered as the first priority. This was, of course, before because I may say that here in the Philippines, maybe 5 to 10 years ago, management of diabetic foot ulcers is really difficult. So when they see a ulcer, which is really at the stage of the critical level or late stage of that ulcer, most of them their legs get chopped or they get amputated, and it's really not good. So unlike nowadays, because of the presence of different wound societies and wound care has been expanding well here in the Philippines, limb salvage is always the priority. So we don't chop the legs anymore, no? And there are always been options and other modalities that should be considered when it comes to treating these patients. And it has been estimated worldwide that every 20 seconds, a lower limb is amputated with diabetic foot complications. And it is the main contributor, ranging from 50 to 70% among non-traumatic amputations. And it is said that if you got your leg amputated, the other one would basically be next in line to be amputated from at least 5 to 7 years from the time of the amputation of the first leg. So as a principle when it comes to wound care, it's always not treating just the whole, but of course the whole patient, the whole person as a holistic management and treatment. And nowadays, this has been the trend when it comes to modern wound management. It is very successful and true and tested in our practice. And when it comes to managing wounds, this is just a basic pathway wherein in our center, when patients come and walk in, most of them go to diabetes center where they get education, they get tested for diabetes. If they are pre-diabetes or diabetes, we do assessment or foot assessment to them, which is a mandatory test for all patients. So if you go to the center and you are suspected to have diabetes or a pre-diabetic patient, you must undergo automatically a diabetic foot screening, whether you like it or not, because it is according to the protocol, so that we can determine if you have a wound already, no wound, or you are a patient who are at high risk of getting these diabetic foot ulcers. At least we can already know and give you the proper care that you want, or the proper care that is according to you or customized to your personality. So if you don't have wound, we teach you foot care. We have different diabetic foot care modules. And also we have endorsed you to other multi-specialty clinics like our nutritionists, the dietitians. We also have to refer you to our life coaches. No, we have life coaches or um, wherein we have determined according to data and studies that patients who have diabetes get psychological effects when it comes to modifying their diet. We or some diabetics might experience that by changing their lifestyle because of their present sickness, which is diabetes, it affects their personality and there is some of them may experience depression. That's why we refer them to a life coach, and we do have a life assessment test which is based in the US, where we also use as a tool and a guide on determining this level of depression for patients who have diabetes. Not only by having wounds, no, by just having diabetes itself, they may get depression. So if they have wounds, no, already present to them, we automatically refer them to the stoma and complex wound care clinic, of course, for management and treatment. Now, we also have used this algorithm and pathways and tools which is very easy easy to use for our wound nurses and also to our doctors, wherein there's no need for narrative reports. It's just a tick box form wherein you can easily see the assessment of the patient who have wounds. And there's no need for you to check, of course, the patient to the bedside or check the patient repeated sessions, wherein by this form, you can easily see the type of wound that the patient have and describe the wound that the patient have. And of course, it has different times and dates or timelines wherein you can easily see the visits of the patients. Now, here in the Philippines, we are still following the concept when managing all types of wounds is, of course, we have the time concept. And I guess I think everyone have already heard about this concept wherein we manage wounds based on the different signs and symptoms that is seen on this concept. So if it's T, it's your tissue or non-viable. Is it viable or non-deficient? If your wound has infection, if your wound has a problem when it comes to moisture balance, or if you are already experiencing the edge of wound problems. Is it advancing or is it not undermining? So basically, that was the before norm. No? That was before the pandemic. Everything that is, we do these things during the normal period. But then we unexpectedly, something came up last December, which is, of course, the coronavirus or the COVID. And this thing has basically has changed our lives instantly, not only in Indonesia, in Manila, in Philippines, but globally. And it's very fast. No? In just one click, everything has changed when it comes to not only to medical practice, but also to our lifestyle and to our daily living. Now, before, this is what you see in the picture is the normal. We do meetings normally wherein we feel that is much more comfortable and personal and intimate to do meetings and gatherings in groups, and we enjoy it with a cup of coffee or some food to share. We go to conventions, seminars in different countries, in different places, and we get to know patients. We conduct lay forums and training programs face to face. We can see the smiles of the patients, we can see the smile of the different people, and we tend to, of course, engage in them in a very comfortable, intimate manner. No? And when the pandemic come, of course, number one that happens and struck us is the fear, and some already have panic when it comes to the pandemic and the COVID virus. Now, it's because of the fear of death and dying, of course, fear of getting infected, fear of course, losing a loved one in a family. And generally, not only that, but of course, the quarantine situation in our country has affected a lot of people, not only locally, but I think nationals and also globally. So traveling is very difficult during those earliest time of the pandemic. And I think during December 2019, we're still not that panicky, or we're really, I think I can say that we're still going easy on that type of pandemic because it hasn't reached our country yet. So we're just saying, it's not going to reach us. It's still in China. It's nowhere until February when we get the first case. And then when we tend to get the first case and experience that there's a patient who has COVID, everybody was in a panic. Everybody tends to buy PPE, even they're not tend to use those PPE. Imagine in just a matter of 1 or 2 days, all N95 masks are gone. Everybody bought their own N95. No, everybody buy surgical masks. So there's really a scarcity of these PPEs to the hospital, and not only to the hospital but also to the public. Everyone is wearing medical grade face mask and medical grade equipment. Now, and then during this pandemic, these are the challenges when it comes to the healthcare. And not only for us who's practicing wounds wound care and wound management, but I think everybody in the healthcare system, in the hospital, faces this type of challenge. And even not only us, but other frontliners as well. Number one is, of course, the fear. No, the fear, again, that's always there. But now we are saying, let's not talk about fear. Let's talk about how are we going to face those fear. Let's talk about how are we going to move on and move forward. Number two is transportation. Because of the quarantine, most of the public transportation was canceled and put on hold. So patient who doesn't own their own automobiles or vehicles cannot go, of course, to the hospital to do checkups or to have their consulted. Number two, they are COVID patients. So that's really scary on their part. No? They're really afraid. Now, number three is, of course, the challenge when it comes to elective and surgical procedures. Most of the elective and surgical procedures are put on hold. No elective surgeries. There's a challenge of patients that are going to undergo debridement or surgical debridement. No patient has been able to do operating room procedures. Hospital is in a full capacity, understaffed due to the pandemic because of the exposure. So most of them are on a skeletal manpower. There's a shortage of and overpriced personal protective equipment. It's very expensive to be confined in a hospital right now or to have a procedure in the hospital right now because of the cost of the PPEs now. Health insurance, COVID swabs, procedures, and also other related procedures that is related to COVID. Hello?
Hello,
Hello?
Mister.
Yes, is it okay? Is the connection okay?
Okay.
Did I get I think I stopped, right?
Okay. Okay, Mister.
Hello? My connection
Hello.
is I had a problem with the connection. Is it now okay?
Okay.
Okay. So I'll continue. I'm sorry about it.
Okay, don't worry, Mister. You
Okay.
can to continue it.
Okay, now like I said earlier, there has been a challenge when it comes to, of course, also negative pressured rooms at the hospital because we did not expect to have this pandemic. So there's only limited negative pressure rooms where you can put your patients with COVID. Another thing is senior physicians cannot go to the hospital again because of their vulnerability, because of their age. And then there's a problem when it comes to the delivery of hospital supplies, which also includes, of course, wound dressings and other materials that are affected by this pandemic. Now, how do we tend to make this all of our patients feel that they are safe in going to the hospital? We tend to erase their fear that you can go to the hospital and it is safe to go to the hospital because that's the number one thing that we want to get rid of, to take away their fear. Because if they have fear, they're afraid to go to the hospital, they won't have their checkups, the compliance when it comes to their treatment and management is really bad. So basically their wound uh, will progress into a late stage or into a poor state. So what we do is there is a screening and assessment for hospitals in our hospital before they go to the hospital to be admitted or enter the hospital. So upon entering the hospital, they are going to be screened. Basically, if they have signs and symptoms, and you can see there that proper distance is observed, and they are given ID bracelets. Now, this ID bracelet, green ID bracelet, indicates that you can only go to the green section of the hospital. the green section of the hospital, you can see there that there are lines directing you. That's where the clean area is. And the yellow area, that's where the COVID area is. So patients or people who have signs and symptoms of having this COVID will be basically going to the yellow area and are going to be screened, and they cannot enter the hospital if they have signs and symptoms. And if you're wearing the green bracelet, you can only go to the clean area and the green. We have also tend to place safety and distancing materials to the hospital, sanitation, floor mats, door mats, and everything to ensure that the patient are safe and they will feel safe. That's what we really want to do. Now, when it comes to safety and distancing, even the elevators and the waiting area are designed in place to maintain safe distancing and provide proper sanitation equipments as well. Now, if it is difficult for them to go to the hospital, we also tend to go digital. So going digital means doing online teleconsults, online consultations. So there are QR codes available all throughout to the hospital or even to the website of the hospital. They can download the hospital application wherein they can have their online book and pay system wherein they can book for consultation for a consultant or a wound specialist to the hospital, and they can talk through different kinds of platforms including Viber and Facebook. So they can have their consultation there, they can show their wounds to the doctor on an online consult or teleconsult, which we call. No? So this is an example of it. So this is the online platform. So we call this the online telemedicine or online consultation, wherein patients can get in touch with their doctor or anyone at the hospital that they want to consult to. Before, of course, they are given instruction when or where they're going to go to the hospital for their next visit. We also tend to release online and mobile apps wherein diagnostic tests can be done at their homes by our hospital by sending people at their home. So extending the care not only to our hospital but also to their homes as well. Now, the challenge when it comes to elective surgery is one of the major concern that we have because during the pandemic or the lockdowns, elective surgeries are put on hold. So there's no elective surgery procedure done during that time to avoid, of course, exposure. The whole country, when it comes to surgical procedure, was as put on hold actually during the lockdown till such time that the surgeons or the Philippine College of Surgeons and the physicians and the Department of Health of the Philippines have decided or released a protocol. So by that time, we have to think of other modalities when it comes to treating patients with, of course, needed debridement. So the only modality that we can assure of is, of course, your autolytic debridement and enzymatic debridement, wherein we use gels and enzymes to soften those necrotic and eschar that is present on the patient's wound so that in a certain period of time that they come to the hospital, we can easily remove those eschar and, of course, the necrotic tissue. But again, this is much more longer. And then after the lockdown, there has been already a policy wherein if you're going to undergo surgical debridement or any surgical procedure, you have to go for a teleconsult. And then after teleconsult with your physician, you have to go for a swab test. If you are negative on the swab test, then the surgical procedure will proceed. If you are positive on the swab test, definitely you will be quarantined on a facility to treat you for the presence of COVID till such time that you are already negative, and that's where we will only proceed with the procedure. Now, when it comes to the change of dressing, of course, we know that basic change of dressing lasts for at least 3 to 5 days. And because of the challenges that the patient have, the traveling and the transportation, change of dressing is done at least 7 days. or longer, provided that we use modern dressings that can address the need of the wound to the patient. So if the patient has an exudative wound, definitely we will use a foam dressing or dressings that can hold that patient's exudates till such time that it can be changed. Or another one is to give health education to the patient's relative, wherein they can do the change of dressing at home when it gets compromised till such time that they go back to the hospital for their visit. So we have lessened the frequency of their visit to the hospital, but at least giving them the chance to visit the hospital for complaisance, for compliance, and of course for proper wound management, because we don't know also if they're at home, if they are taking care of the wound properly or dressing the wound properly. So although we give them proper education as well. Now, another challenge, of course, is the availability of these dressings to the public. So we make sure that we use dressings that are widely available in the market and not those dressings that are only available at the hospital or difficult to find for the patients. Now, another thing that we tend to give focus on is to teach the patient and also their healthcare provider at home, if they have, the proper way of changing the dressing and reinforcing the dressing. So basically, we have a primary dressing that addresses the management of the wound, a secondary dressing that would address the exudate so that the dressing would last, till the time that they have to come back to the hospital or much more longer for them compared before that they have to go back to the hospital more frequent. And of course, a dressing that would protect the integrity of not only the wound, but also with the primary and secondary dressing. And also by looking to dressings that are available in the market that best have this can best have these different traits in just one dressing, which must be more cheaper. Now, because of this, we also tend to offer continuity of care. So, due to the pandemic, people are afraid to go to the hospital. Therefore, compliance treatment regimen is difficult, and thus we tend to do medical home care service. So, by doing medical home care service, we tend to guarantee patients compliance when it comes to the treatment, and can see the patient's wound, firsthand, and can be better taken care of. Although we're still doing the same protocol and the same pathway that we have the hospital when it comes to treating this type of diabetic foot ulcers. Now, another modality that was used nowadays, which is very, very much more in when it comes to the numbers, is of course the use of negative pressure vacuum therapy, because it lessens the change of dressing, addresses the exudative level of your patient's wound, and at the same time, less contact to the patient, and the patient can stay at home. No, so we can see here that KCI is one of the brands that we're using here. Can see that wounds better granulate and heals much more better when placed on a negative pressure wound vacuum therapy. So better cell migration, better granulation of the wound, and at the same time, wherein we're concerned with the contact of the patient and them going to the hospital is addressed. So no need for them to go to the hospital. We attach the wound vacuum therapy machine at home. We visit them at home, or they can go to the outpatient clinics of the hospital for a certain period of time, longer, than doing the change of dressing. So if they have to go to the hospital every day or every 3 days, but when you have a wound vacuum machine attached to your wound, so they have to go to the hospital at least 7 days to 10 days maximum. Now you can see here that a wound can best granulate, especially for wounds that are larger in size. It can be best addressed by applying this negative pressure vacuum therapy. I have no brands in particular, but there are many available brands in the market right now that can do the same principle and the same wound management and treatment when it comes to negative pressure. Now, it is always said that yes, we have this type of treatment and management. We have these different modalities, but it is said that it's always the prevention that is better. No? So by doing prevention and having many clinical pathways in managing your patients' wounds, and we can address them properly, customized care for patients who have diabetic foot ulcers or any other type of leg ulcers, we can advise them and have a better result in the future. So prevention is better again by cure, no, than cure. Now another modality that we give emphasis nowadays is of course counseling and health education modules. Now we have also online counseling and health education modules that are given to the patient and also to the relatives, both for stoma and wound care. So if they have problems when it comes to changing the dressings at home, we again going back to the teleconsult and telemedicine, they can go and apply for a schedule. We can have an online interaction when it comes to treating their wounds, and of course by giving them different counseling and advices on the change of dressings or when are they going to come to the hospital as well. And of course again taking back that they are still afraid. And this is an interesting thing because when it comes to the pandemic, the only department that was not affected in our hospital setting was the wound center. Surprisingly, the census when it comes to ostomy and wound care did not drop during the pandemic. Other departments have closed, no? Other departments have closed, but there are only, I think, some departments that remain strong during the pandemic. It's the hemodialysis unit, the pulmonary unit, the stoma and wound unit. Other services have problems when it comes to the census, or there has been a drop when it comes to the census. Of course, the hospital admission has dropped to the lowest up to 30% during the pandemic. But nowadays, it's going back up to 60 to 65% because the government has been now the strictness of when it comes to the community guidelines, quarantine has lessened. And nowadays, there are much more transportation that are available, provided it has when you go to a facility, you must wear a face mask and a face shield. So it's a must. So you cannot enter a facility here if you don't wear a face mask and a face shield. So it's a must and a mandatory. Transportation is back up to 50%. Now, going to the basics, of course, this is very important when it comes to managing diabetic foot ulcers or managing patients with wounds. This is the importance of foot screening. So we do comprehensive foot evaluation, we do the Doppler, we do the monofilament test, we do neurologic evaluation test for the patient's leg if they are already have a diabetes or a pre-diabetic condition patient. So these are the things that are included on those tests. And this, I guess, is a different discussion and topic because this may be long. We also do podiatry care, no? Nail care, callus removal, orthotics, diabetic foot care, and education. And again, the importance of limb salvage when it comes to these things now. And I guess this is the new normal that we are facing, and like what we always say, that it is time to adapt, and adapting to this new normal may be difficult to many of us, but we have to again accept this as the future, or what we're going to experience is this thing. And like the saying here, that things may never go back to the normal, but you may need to create a new normal, no? And that is okay. That's why we tend to, of course, encourage also other people at the hospital to share their ideas, disruption of the processes and systems that may tend not to work anymore because of this pandemic. So everybody is engaged, not only people at the top management, but also We also tend to encourage people at the ranks to verbalize their concerns and verbalize their ideas. Any ideas is accepted nowadays, because these things are new to us and we did not expect this to happen. Nobody has experienced this type of things, and we should share each other's ideas for the better of everyone. And I think this is going to be my last slide, wherein I always say this, that everybody can do wound care. So I think it's true. Everybody can do wound care, but you can do anything, but not everything. Always remember your scope of practice when it comes to nursing and when it comes to medicine, I guess. And wound care is multidisciplinary, as like what we always say. And don't treat wounds by yourself. Always consider other people as well, because they might have a good idea or a good share when it comes to treating the patient. And anyway, it's not for the benefit of us as a healthcare provider, but for the benefit of our patient as well. So I think that would be all. And thank you very much. I do hope that you have some questions. Thank you very much.
Okay, Mister, thank you for your nice expertise on wound care. Hello, Mister.
Yes.
Okay.
Hello. Yes.
Okay, Mister, you can to take a rest for a little time because
Okay.
it's waiting for a question.
Okay.
Okay, Mister. Oke, untuk seluruh peserta bisa yang ingin bertanya bisa langsung di kolom chat ya. Oke, hello Mister.
Yes. Hello.
There is a question.
Okay.
There's a question from Indonesian audience.
Mm-hmm.
His name is Mr. Khaidir Bashar.
Mm-hmm.
The question is, oh, okay, this is pandemic era. What's the management of diabetes wound care for patient positive COVID-19 in isolation room, and what
Mm.
to use in a wound care of this patient? Okay, can you get
Okay.
my point?
Yes. Thank you very much. It's a very
Okay.
nice question. Thank you. Now, what we have done, because we are also taking care of patients with COVID as well. So the intensive care unit or the isolation unit was divided. So there's also a clean area and a negative or a isolation area. So before we only have one isolation area, but now we have five isolation area, 5 floors. No, before there's only one. Now there's 5 floors of isolation area, and there's only one wood nurse who's going to make his or her rounds all throughout that isolation area. So one thing that we're going to do is schedule the patients that we're going to take care. We don't share the management. So I put a dedicated wound nurse for the clean area, and then there is a dedicated wound nurse for the isolation area. As much as possible, we tend to lessen the visit to the patient because, again, of the scarcity of PPE. Because once you enter that area, you're going to wear PPE. And when you're going to visit just one patient and you have worn a PPE, that is a waste already. No? So what we're going to do is have a schedule, triage your patients, which one is going to come first. So you have to make mild wounds to moderate wounds to chronic wounds to very difficult wounds. And as much as possible, again, like I said, it's the same that we put dressings that can stand longer compared to compared than the normal dressings that we use. So you have to put dressings that can be that can address the exudate much more longer. And then we tend to by the time we also train staffs, and we call them champions, no, the wound champions. So that initially they are already at the COVID area. They're the one who's on duty on the COVID area. So they are there 12 hours wearing PPE. So when there's a wound at that area, they are the first frontliner, first line that is going to check on the wound. Now, there is already an algorithm placed on the charts on what are the dressings or management that a nurse can do on this type of wounds. Now, when it comes to the variants, just in case that the wound dressing is not effective, that's the time that the wound nurse specialist will go to that department. And we send the pictures or the videos of the patient's wounds and the condition through our hospital information system. So the different nursing units with isolation department, they have a tablet with them, bring it to the patient's room, put a video or put it on capture a picture of the wound and send it to the different disciplinary discipline of care. So that includes the attending physician, that includes the wound specialist, and that includes also the surgeon who's taking care of the patients. And then yes, we already have algorithms placed. So if it's a stage one pressure injury, this is what the nurse is going to do: clean by this irrigation, put this type of dressing, secure the dressing, and then they document. If they have venous leg ulcer, they have this type of dressings that they use, no, and they put it in documentation and put it on the tick box list. So that's how we manage this the patient's wound during this pandemic. But most of them, we use a lot of foams actually. We use a lot of dressings that has silver and dressings that have antimicrobials and antibacterials so that it can stay much more longer and can address the patient's wounds infection or prevention of infection as a matter of fact. Because if we're just going to put ordinary gauze, that would be again a problem. So yung the frequency of the visits to the patients is an issue. And in here in the Philippines, PPE is really an issue. And we have to really strategize when it comes to visiting patients at the isolation. When it comes to treatment and management, actually it's the same because the wound it's still the same. They react to this dressing the same. The thing that is different is the approach to this patient who has COVID because we don't want to be exposed and we don't want other patients to be exposed as well because we are considered as a transport of this virus when we transfer to the patient. Second, when we leave the isolation area after taking care of patients with wounds, we have to take a shower. So there is an anteroom. There is an area where the nurses, the healthcare provider, change their clothes, remove their clothing that is worn on the isolation area. They have to take a shower. They have to take a shower before going at home as well. I hope I
Okay,
answered.
Mister. Okay. So the guideline of your answer is the first is
Yes,
making schedule for patient, and then make a
yes,
triage to like where what the patient a chronic wound or
yeah,
acute wound. So the next is
yes,
with online consultation, right?
yes, correct.
Like sending a picture what kind of wound and what the wound will be treated, and
Yes,
then management dressing
mm,
is the same, and
correct.
the different is approach to
Yes,
do
uh,
their wound.
correct.
Okay.
There's also one more thing because of the pandemic, most of the surgeons would also limit their visit to the patient as well. So, like I said earlier, that surgical procedure is really difficult. So, because what we have experienced is that during the first months of the pandemic, there are many healthcare workers, nurses, and doctors who died actually.
Right.
They died because of the exposure, and many surgeons and many physicians are already on the senior age and vulnerable to this virus. So during the first months, actually there is no the surgery, the census when it comes to surgical procedure has really dropped. Sometimes it's zero, no surgical procedure. So it's really a challenge. So we have to sort to another modality which is much more conservative, longer conservative, but again still effective.
Yes, Mister. Okay, it mean all the except doctor or surgeon, we nurse in Philippines will must to break their limit and break their limit, make
Yeah.
critical thinking what to do to treat the wound without a
Yes.
surgeon or without a doctor, right?
Yes. Agree. So we give them proper training online, short courses online on how to be a wound nurse for a basic guideline, basic wound nurse,
Basic.
because most of them, some of them are intensive care nurse. Of course, they don't have any interest in wound care. I'm an ICU nurse. I'm an stroke nurse. I'm an anesthesia nurse. I'm a renal nurse, hemodialysis nurse. They don't have any interest in wound care as well. So here comes the pandemic, and then my wound care nurses, are we allowed to go there?
Yes.
Are we allowed to go to the COVID area? How are we going to go there? Someone told us that the patient has a pressure injury, but are we going there? Are we allowed to go there? So that's the question. So we tend to mix things up with them by giving them proper information and crash course on basic wound care online.
Yes.
Imagine that. And it's really a challenge, but imagine it's doable. It's doable. We have right now we have accomplished it, and thanks to God, no, ma- my wound care staffs up to now, none of us got infected. None of us are exposed. And none of us are exposed. And the really the key is being very careful. It's really being careful. And we use respirator masks. We
That's right.
don't use N95 anymore because there's no N95 available. We use respirator masks instead of N95. We save money. We save the cost of using surgical masks, ordinary surgical masks, or N95 masks. We use respirator masks, and we just disinfect them with the proper guidelines that is given to us by the hospital infection control.
Okay, Mister. It's
Yeah.
so good answer. So the summary is, as a medic, not only nurse, we have to break the limit. We have to break the limit to treat anything for
Correct.
patient.
Correct. Agree.
Okay, just wait, Mister. I want to translate your question for the audience
Okay.
because the question is Indonesian bahasa.
Bahasa. Ako sikit.
Ya.
Bahasa.
Oh, bisa sedikit, bisa sedikit.
Sige nga.
Oke, tadi pertanyaan dari Bapak Haidir Bashar terkait dengan manajemen diabetes waktu pandemik. Jadi pada intinya, yang pertama dilakukan di Filipina adalah membuat jadwal terperinci untuk visite kepada pasien-pasien yang mana terkonfirmasi COVID-19 dan juga membutuhkan perawatan luka secara rutin. Nah, dibuatkan jadwal terperinci seperti itu, kemudian dibuat triase. Mana-mana pasien yang memerlukan ataupun memilah-milah mana ya pasien dengan luka kronik dan luka akut yang perlu penanganan terlebih dahulu didahulukan. Dan juga untuk menentukan dressing yang tepat untuk masing-masing pasien. Kemudian setelah itu juga bisa melakukan online consultation, jadi bisa secara interaktif mengirim fotonya ataupun video bagaimana kondisi luka tersebut untuk mendapatkan perawatan dan juga dressing yang tepat. Selanjutnya, menentukan manajemen dressing. Tapi di sini di Filipina sendiri untuk manajemen dressing tidak ada bedanya yang digunakan selama ataupun sebelum COVID-19. Namun yang dibedakan hanyalah pada pendekatannya. Di sini pendekatan karena memang COVID-19 untuk penyebarannya atau sangat rawan untuk menular kepada tenaga medis seperti itu. Bagaimana Pak Haidir Bashar? Sudah jelas ya untuk jawabannya? Okay, Mister, I want to choose the next questions. Are you ready?
Okay. Yes, I'm ready.
Okay. Okay, wait. Okay, Mister, there is a question from Miss Maria Andriani, Indonesia. The question is, there is a patient with diabetes. If there are patient who have to be amputated, is there no other method beside amputation? Okay.
Yes, actually,
Other ways.
nowadays conservative, so we don't chop the leg immediately. The amputation is considered late unless it is really on the stage that it has to be amputated. First thing that we are going to do, of course, is to check the leg. There are different stages when it comes to diabetic foot ulcers. We have the Wagner classification or the Texas classification. Now, even though in here in the Philippines, if the patient, even though it is really advised to amputate the leg, if the patient doesn't want to have the leg amputated, you cannot. If there is no consent, even if the leg is infected, even if you tell them that they're going to die if we won't have the leg amputated because it's septic, if they did not sign the consent, we cannot amputate because it's their choice. Now, other modalities that you have to do is, of course, number one, to keep the foot, the infection. So check, do a blood culture if the patient is already septic or not, if there is already sepsis. If there is no septic, if it's dry gangrene, we tend to just let it be like that, remain it on the dry gangrene, because if it is converted to wet gangrene, basically it's a good medium for infection, it will get infected. They will go to the hospital as a protocol for sepsis protocol. If you, to avoid, sepsis, they have to be at the hospital, monitored, given antibiotics as well. If they don't want to get amputated, they have to sign a waiver that the doctor already advised for amputation, but they don't want to get amputated. Other modalities that you can do when it comes to foot, of course, first they have to debride, time concept. Take out those necrotic tissue, take out those scar tissue, because that is the goal. If you don't take that out, the wound will not heal definitely. Preparation of the wound bed, even though it is for amputation, we tell them that this is not a guarantee, because wound, of course, is a holistic thing. They're diabetic, they have to control the sugar. Now, another one is they have this oxygen therapies, adjunct therapies that can be available to the patient. Not only the vacuum machine, hyperbaric is considered one, no, but it's only an adjunct therapy here in the Philippines. No, hyperbaric therapy is an option because it's very expensive. Also compared to negative pressure vacuum therapy, it's very expensive. There's a question here saying about other improvised tool when it comes to negative pressure vacuum therapy. Yes, there is. Another thing is the oxygen, topical oxygen therapies. They have this Natrox thing, the gadget that gives oxygen to the patient's wound to provide oxygenation. Another thing is you have to do a venous and Doppler ultrasound to the patient to check the blood flow if there is insufficiency already on the patient's leg, so that you can tell them that the probability of the healing can be only at this percentage because of this. So everything, before you do anything, you have to inform the patient. You have to inform the patient what is the probability. You have to be honest to the patient. What is the probability? This is the different option, and this is what is going to happen on this certain option. So we let them be partners in care. No? So these patients, the decision, we include them so that at the end there won't be any, blaming to the health worker saying that you did not tell us. Especially if the bill is going high, no, they tend to forget everything. If when it comes to the paying, no, and the bill is already 1 million, oh, why didn't you tell us that this is going to be the result? You told us that this is going to be successful, because sometimes people think if you did not explain it to them very well, they think that when there is already a wound specialist involved, you're like Harry Potter, no? That when you're there, everything will be like a magic that it will be healed. No, it has to be explained to them. It has to be well explained. Every procedures, we let them be involved when it comes to the decision making. So if they don't want to be amputated, yeah, we won't, because you don't want to. These are the different options. These are the consequences, and this may be the possible result.
Okay, thank you, Mr. Ryan. So the first way to treat the patient that have situation of that is classification. We can to use Texas classification or Weber classification for ankle, right?
Yes, yes.
And then treat the modality of nurse, like
Mm-hmm.
mm, CFCN nurse,
Mm-hmm.
and there are more opportunity to recovery without amputation if the wound is not getting septic, right?
Correct.
Okay.
Mm-hmm.
Oke. Jadi untuk Ibu Maria Andriani di sini, misalkan pasiennya sendiri tersebut harus dikategorikan terlebih dahulu dengan Texas Classification dan juga Weber Classification. Apakah kondisi lukanya tersebut sudah mengarah ke sepsis atau belum? Nah, misalkan sudah atau misalkan belum mengarah ke sepsis, nah ini bisa dihindari untuk amputasinya dengan perawatan secara rutin dengan dressing-dressing yang dengan apa namanya itu kadar yang lebih tinggi. Okay, Mister, are you ready for the next question?
Yes, yes. I'm ready.
Because in Indonesia, the audience is so enthusiastic for you. There is a lot of
Yeah.
questions.
I see on the chat there's a lot of questions.
Okay. Okay, sir. There is a question from Sevita Fasha. Ibu Sevita Fasha. Excuse me,
Mm-hmm.
sir. I want to ask about hyperbaric therapy. I hear this therapy have a good impact for diabetic wounds. So about in the Philippine hospital, is there use
Mm.
this therapy also?
Yes, yeah. I myself have trained, I think 10 years ago, in hyperbaric therapy in Malaysia. So although there are many few still medical studies, and when it comes to hyperbaric therapy in treating wounds, no, there are still some questions going on. But yes, there are hyperbaric therapy here in the Philippines, and we use them for patients who has, of course, diabetic foot ulcers. But when you do hyperbaric, you still have to dress the patient's wound. So you do the normal dressing before you put the patient on hyperbaric. Number two, when you use hyperbaric therapy for patients who has diabetes, you have to monitor the blood sugar, because patients who undergo hyperbaric therapy, their blood sugar tend to drop. They tend to go low. They tend to drop. Patients who undergo hyperbaric therapy with diabetes, their blood sugar tend to drop. So you have to monitor it. Number three, hyperbaric therapy is not covered here in the Philippines on our health insurance system. So patient has to pay it on their own pocket, ranging for I think maybe per session in a day. How much is I think around 2,000 ringgit, Malaysian ringgit.
1,000 ringgit.
Around 2,000 Malaysian ringgit per session per day. And you need 13 sessions to see a granulation or to see a wound reaction. So it's really quite expensive for the treatment. But yes, there are hyperbaric therapy oxygen centers here in the Philippines.
Okay, Mister. So it's so expensive dressing, right?
It is
Hyperbaric
it
is.
is it is expensive.
So
Mhm.
is like the last options, the last option for recovery or
Yes,
wound
it
care or
is
not?
it is it is an adjunct therapy. It is a last option if it is also offered as an option to the patient if the patient has the funds to do it, has the money to do it, then they also sign a consent for them to undergo hyperbaric therapy. Even by using vacuum therapy, because it's expensive, they have to sign a consent or a contract.
Okay, because it's not included in insurance, right?
Yes, it's not covered.
Okay. Okay, Mister. Thank you.
There is a question here
Yes.
there is a question here, Dwesti Eka Ratnani
Eka.
from Viva Medica Clinic, Jakarta, saying, can you share your experience for patient who has low self-esteem and confidence because they have amputated extremities, and how can this management can help to still follow up the diabetes management? Okay, thank you for the question. One, you have to make a good support group. You have to make a good support group where you can have this patient join. Second, like I said, we have a life coach or a lifestyle assessment management program wherein there is a psychologist on board or a psychiatrist on board, but we don't tell them that they're psychologists or psychiatrists. No? We just tell them they are life coaches, because if you tell the patient that they are going to be referred to a psychiatrist, they would say that why would I go there? I'm not a a cuckoo person. So they definitely, we just tell them life coach, because definitely they might be experiencing depression because of the loss of the limb. Another thing is we tend to send them to lay forums and therapy sessions to the therapist, so that they can undergo exercises and how to take care of the stump or the wound, because sometimes after the surgery they don't go back to their surgeons. So if they don't go back to the surgeons or they don't back to the hospitals, they only go back when there is already blisters on the leg or the wound did not heal well. I think that is, I hope that I answered that question.
Okay, Mister. Thank you for a question for answer from Dwesti Eka Ratnani
Mm-hmm.
dari Rumah Sakit Viva Medica Clinic IAWHSM Jakarta.
Mm-hmm.
So it's important to give a counseling
Yes.
for
Mm.
up their self-esteem,
Yes. It is very important.
because I think if the patient have a low self-esteem, it give impact for the wound,
Correct.
right?
Mm.
Okay,
Yes.
and there is a need a long period for recovery,
Mm-hmm.
because the psychology make impact for the body, right,
Agree.
Mister?
I agree. Mm-hmm.
Okay, I choose for the last question. There's
Okay.
many question. Okay, there is a question from Hangger Putro, Mr. Hangger Putro
Yes.
Pangarso
Yeah.
from National Hospital Diponegoro.
Mm-hmm.
The question is, I have heard that the use of vacuum tool, as you explained earlier, is very effectively in wound healing. It can accelerate wound closure, especially broad and deep wounds, but the price is very expensive. Is there any modifications of the tool so that it is more affordable for
Yes.
people who do have more cost?
Agree. I agree. Same here. In the Philippines, it's very expensive. And yes, there is a way or a method to do wound vacuum therapy with a modification or an alternative. So, but these are only done if really there's no wound vacuum available, a modern machine, or the patient really don't have the funds to do so. And basically, you can see this here in the Philippines on government hospitals. Now, you need a suction machine, ordinary suction machine. We use bed mattress foam. It is autoclave bed mattress foam. We use Foley catheter set, a Foley catheter. We put holes on that Foley catheter. We connect it to the suction machine. We put the Foley catheter inside the foam, mattress foam that is cut customizedly. That's what we put on the patient's wound. We cover with a transparent film, a Tegaderm, an offsite, or any transparent film. But again, all of your materials must be sterile. So it has to be regassed or it has to be gassed or it has to be placed on a sterilizing machine so that when you use it to the patient, and this is off-labeled use. So meaning it is not really advised. So when you're going to do this, there are complications or consequences that you have to inform the patient, and at the same time, if your hospital would allow you to do these things. Because again, for private hospitals who have JCIA accreditations, who have accreditations for safety and patient guidelines, definitely they would not allow the use of such modifications, especially when it comes to this, no, because of safety. But this, the modifications that I have told you, the improvised method is used in cases that there is really no available and it is really on an emergency situation. But again, if it's not, if there is an available machine, as much as possible, use the machine and not the modified version. Because again, this procedure, the wound vacuum is effective, but this is just only also an adjunct therapy. It's an option. So if it is not, if the patient cannot afford, you go to the next other option available to which the patient can avail such management and it is safe for the patient, which is the best, I think. Okay? And
Okay,
everything,
Mr.
the patient must agree that you use this, this is off-label use. Again, because when it comes to legality, something went wrong and then the patient died, they might sue you. No? They might put a legal case against the healthcare provider. And it's in here in the Philippines, it's really easy to sue everyone. It's it's uh, it's just like buying hot cake in a bakery. So you have to be very careful because people nowadays are really very particular when it comes to medical malpractice.
Okay, Mr. Thank you. So it means it depends on how creatively
Yes,
the wound care nurse to
yes.
make a
As long as the
alternative way.
principle,
Okay, yes.
yeah, as long as the
To make
principle is there, yeah.
okay as far okay. Okay, Mister. There is the last questions from Mr. Hangir Putro,
Mm-hmm.
and you have to give answer.
Okay.
Okay, Mister. Thank you for your sharing with us, and thank you for your talking time. I know that you are a busy person, Mister. So,
No, I'm not. It's a
no,
pleasure to be joining you guys, and I really miss Indonesia because when there's no pandemic, I think in a year I go visit Indonesia for 2 or 3 times. Go to visit
three
Indonesia.
times. Uh,
Yeah. Yes.
where the last place you have visit?
In Bogor,
Oh, in Bogor.
and in Solo
For for
for
vacations or
conference.
just for work conference?
Conference, yes. Also.
Okay,
So it's like a
Mister.
second home to me.
Okay. Once more, I'll thank advance. Thank very much, Mister, for your nice
Thank
expertise.
you. Thank
Okay,
you.
Mister. See you.
Thank you.
Halo seluruh audiens yang saya hormati. Selanjutnya kita akan mengundang uh, pembicara kedua ini dari Korea Selatan. Sebentar, saya persiapkan dulu. Oke, saya harap seluruh audiennya masih tetap semangat ya. Paling tidak di sini juga yang belum bisa bahasa Inggris bisa belajar bahasa Inggris, dan karena ini memang internasional seminar, jadi untuk pembicaranya juga PPT-nya bahasa Inggris dan kita belum bisa untuk mentranslatekan dari PPT-nya sendiri. Jadi memang dari judulnya sudah internasional, jadi saya harapkan nanti untuk audien juga mendapatkan poin-poin yang disampaikan dari narasumber. Okay, thanks for your nice impressions. So I can hope to invite the next speaker. That's right, she's from South Korea. Her name is Miss Han An-jin, registered nurse, Magister Science Nursing, certified food care nursing. So it's now my pleasure to introduce our guest speaker. Mr. Han An-jin is a professional wound anatomist continent in nursing severance department of Yonsei University Hospital. She's wound care nurse in Yonsei University Hospital, and she has license of certified wound care nurse, certified food care nurse, Korean clinical nursing, advanced practice nursing, and New York Nursing Board. And right now, Mr. Han An-jin as a wound care nurse on diabetic food clinic in Yonsei Hospital also. And the second day, she will show up her material about the themes, diabetes tissue, infection, inflammations, moisture balance, and age preparation concept 2020. Okay, that's way. So I will to ask you for giving our nice intention to invite her to join with us. So please welcome Mr. Han An-jin, registered nurse, Magister Science Nursing, certified food care nursing. Hello, Miss Han An-jin. Hello. You can switch on your. Hello, Miss.
Hi.
Hello.
Can you hear me?
안녕하세요. Okay.
Oh,
안녕하세요.
안녕하세요.
어떻게 지내?
어머나. I'm good. I'm good.
Okay,
Nice to
I'm
meet
good.
you. Yeah, thank you for inviting me.
Okay, I can speak in Korean just a little, Miss.
Yeah, but you're perfect. Yeah, pronunciation is perfect.
Okay. Okay, hello, Miss. Are you good today? Are you good today? Are you good today?
Yeah.
How are you today? Okay.
Yeah,
So,
yeah,
Miss,
I'm good.
okay. What time in Korea right now?
Now 11:40, almost 12.
Okay, Mister. So today I will really appreciate for your presentation today about the dance concept to 2020. Okay, are you ready, Miss? For start it?
I sent my video. Is it right?
Right.
It's not live.
Okay.
Yeah.
Okay. Okay, Miss. Before it, can you give a greeting for all audience in Indonesia with saying "Hello Indonesia, apa kabar?" Okay. Please say
Can you
okay.
repeat?
Hello Indonesia. Apa kabar? Please. Okay.
Apakah deh?
Apa kabar Indonesia? Please follow me for saying. Apa kabar Indonesia?
Apakah deh? Right?
Okay.
Difficult. Not apakah deh?
Apa kabar?
Apa kabar?
Okay.
Apa kabar?
Okay. Wait, Miss.
Oke, Mbak Sera, saya bantu untuk videonya ya.
Yeah.
Good morning, everyone. I'm grateful to speak to you today. I'd like to start by introducing myself. I'm Moon-jin Han from Korea. I have been a wound care nurse at Severance Hospital for 13 years. I'm an advanced practice nurse in Korea and qualified as a wound care nurse and food care nurse in the United States. Also, I work as an academic director of the Korean Wound Management Association and the Korea Diabetic Food Association. I'm very happy to share my experience with you from Korea. I'm here today to present management of chronic wound during COVID-19 pandemic. So I organized the two contents as follows. COVID-19 changing our daily life all over the world. Things that one problem in the past are now problems. Hospital may have changed the most because of COVID-19. Patients in hospital have experienced more difficult to meet doctors and be treated. Also, patients are afraid to visit the hospital frequently because they are afraid of getting infected at the hospital. COVID-19 also caused the problem with new chronic wounds. In order to solve this problem, wound experts are gathering again to find and share solutions. So, first of all, I'm gonna talking about issue related to wound care. After that, I will share what I'm doing to prevent COVID-19 at the hospital. The first one is the issue related to wound care. The COVID-19 is a great threat to all of us. COVID-19 is more dangerous for patients with chronic wounds. Also, the COVID-19 can cause a chronic wound. The healthcare workers are also a group that needs to be protected from COVID-19. Chronic wounds are commonly related to some comorbidities. Comorbidities increase the risk of death from infection with a severe acute respiratory syndrome coronavirus. COVID-19 is highly contagious and spreads through human to human transmission with a relatively long incubation period. This incubation period is a median time of around 6 days. During the incubation period, asymptomatic carriers can infect others. Let's first take about patients who are at high risk of COVID-19 infection. Non-healing wounds have many fundamental medical problems. On the other hand, various medical problems cause non-healing wounds. Most patients with chronic wounds have multiple disease, such as DM, hypertension, and CKD. Let's take a look at this table together. This is a part of a paper published by Stella in 2020. As a result, 81% of cases were accompanied by heart disease. Next, diarrhea patient were 60% higher. Next, PAOD patient was 50%. The sum of the percentage is 100% because there are multiple responses. This has an important meaning. This meaning the most patients have multiple disease, not only one disease. This material is also interesting. This is a risk factor that could lead to severe COVID-19 classified by the CDC. This risk factor includes heart disease and diabetes, high and chronic injury patients. You can predict that they would be more dangerous if a patient with a chronic wound become ill with COVID-19. Let's take a look at this material that Richard reported. This is about the disease that the patient has with COVID-19. DM and heart disease are at the top of the list. Because of this increased risk, efforts to decrease exposure to virus are the most important in patients with chronic wounds. Patients with chronic injury are a high-risk group that will be severely impacted with COVID-19. Because we can't eliminate risk factors, we need to make every effort to be safe for the patient. Next, we will talk about chronic wounds that occur in COVID-19 patients. In addition to injury risk factors, COVID-19 is associated with a physiological change that may affect healing. In other words, COVID can cause wounds as well as delayed wound healing. This is a paper reported by IAWHSM in France. She mentioned the skin vascular symptoms of COVID-19 patients. Those are clinical feature of COVID-19 patient with the skin vascular symptoms. Photo A shows a patient in ICU for history. Photo B is the chest of a patient who only complain of chest pain and cough. In the picture C, you can see Raynaud phenomenon. The symptoms are beginning to appear in 10 days after fever and cough. Chilblains G is eruptive cerebral angioma after healing of clinical symptom COVID-19. The pathophysiology of these lesions is unclear, but may include immune dysregulation, vasculitis, vessel thrombosis, or neoangiogenesis. We can guess. In addition, with the downregulation of angiotensin converting enzyme 2 in association with the severe acute respiratory syndrome coronavirus infection, accumulation of angiotensin 2 occurs. In addition, severe acute respiratory syndrome of coronavirus infections reduce the secretion of angiotensin transferase 2. This causes the accumulation of angiotensin 2. Accumulation of angiotensin 2 leads to vascular contracture and increased vascular permeability. Therefore, it affects the skin. Direct thrombogenic effects can also lead to tissue ischemia. This is a case reported by Sarah Young. 39 years old patient had a urticaria on her trunk side back. The rash began a day before the fever. Soon after that, she was diagnosed with COVID-19 and so far had a related mild cause of disease. Most healed spontaneously, and studies have reported no correlation with COVID-19 and healing. But we need to focus on here is a decline in the patient immune system. Depending on the severity of COVID-19 infection, the patient's overall immunological condition can damage wound healing. Acute wound is normal, as individuals heal easily. Because people with normal immune system activate normal wound healing mechanism. If the patient is exposed to disease, the immune system isn't good. They have elements that interfere with wound healing. If COVID-19 causes immune degradation, wound healing can be delayed or deteriorated. So we need to reset the wound treatment goal and plan the treatment. Another interesting thing is that the posture for COVID-19 treatment causes pressure injury. This is a new experience of pressure injury that we've never experienced before. Prone position makes ventilation more homogeneous. As a result, reduces alveolar distension, limits ventilator-associated lung injury. The result is improved ventilation and oxygenation, which many patients obtain even after they return to supine position. Prone position is known to help treat damaged lungs. MPIAP is a representative group that studied and educated pressure injuries. Because of the increased incidence of pressure injuries caused by the prone position, this year MPIAP put more emphasis on preventing pressure injury during the prone position and provided a lot of evidence and carry out activities. Let's take a look at the pressure injury prevention guidelines suggested by MPIAP during prone position. First, these are general tips. MPIAP first emphasized the use of surface surfaces and positioning devices. It is recommended that the prone position be taken as if you are swimming. Once the right arm goes up and the left arm goes down, as shown in the picture. And next, the left arm goes up and the right arm goes down. Since it isn't easy to turn the position open, small position change were allowed, as if only arm and leg were moved little by little. Lastly, when alternating arm position, you should assess the skin of arm, head, face. The pressure point of the diagram corresponds to the body surface facing the mattress. Nurses need to be aware of this pressure point, distribute the pressure, and try to assess the skin in this area more frequently. Especially, they emphasized the prevention of pressure injury in the face area because the face doesn't have much fat and muscle. If a pressure injury occurs on the face, there is a high possibility that it will proceed to stage 4. These are the recommendations they made. Apply prophylactic dressing to the face. Control the moisture because the face is a part that can be easily moistened with oral secretion. Also apply foam dressing under medical devices to prevent device pressure injury. And don't forget to apply thick foam. The overall position change is done every 4 hours, but the face is changed little by little every 2 hours. This recommendation can be downloaded from the MPIAP homepage. It is necessary to read the full text before implementing the prone position. It is another chronic wound issue in COVID-19 patients. Is this the pressure injury? It looked like DTPI, but it's not pressure injury. It wasn't the part where the pressure was applied because this patient was maintaining prone position. This wound is not pressure injury at all. Pressure wasn't applied at all because the COVID patient was maintaining the prone position too. Cell biopsy has been performed. As a result, they lack pressure-induced injury to underlying soft tissue cells. And the skin change likely represents tissue ischemia due to clotting. After confirming that the skin change isn't due to pressure, wound care nurses should not label this skin change as DPI, but rather potential skin manifestation. Further study is required. We need to pay attention to this result. The follow-up issue for the healthcare workers, not the patient. Wound care nurses can expose themselves to COVID-19 when take care of patients with chronic wound care. COVID-19 testing hasn't been implemented for routine wound care. COVID-19 is present in the respiratory droplet, but little is known about the shedding of the virus in body fluids and associated risks. While COVID-19 has also been identified in saliva and mucosal secretions, there has been no identification of COVID-19 in the tissue or fluid. Nevertheless, the wound care nurse will have close contact with the patient during the treatment. So, you should be careful to prevent person-to-person transmission. This picture is very famous in the world. Has created an issue about how hard the clinical workforce is working in COVID-19 environments. The wound experts thought differently when they saw this picture. We are worried about the pressure injury caused by a device. So MPIAP also prepared the recommendation of device pressure prevention from PPE. The guidelines to prevent pressure injury are for healthcare workers. First, you should make your skin healthy and dry before applying the N95 mask. The second one is at least 5 minutes every 2 hours and ideally 15 minutes every 2 hours to reduce the pressure. Third, this is the most important part for safety. When you When you use thin prophylactic dressing on your nose or cheeks, you should recheck the seal of the N95 mask. And then, when removing the thin prophylactic dressing, you should close eyes and avoid inhaling any aerosolized virus. We were talking about COVID-19 issue related to wound care. I talked about the issue of the patient and the healthcare worker. As the underlying disease of patient with chronic wounds match the underlying disease of the COVID-19 high-risk group, it is important to protect patients with chronic wounds from COVID-19 infection. Also, I told you more about risk for chronic wounds in COVID-19 patients. The infection of COVID-19 will affect the immune system, so the chronic wound healing mechanism will function properly. If COVID-19 causes immune degradation, wound healing can be delayed or deteriorated. In addition, we reviewed the case which skin vascular symptom appearing COVID-19 patient. We looked at the facial pressure injury that occurred during the prone position. Finally, when applied PPE for healthcare workers, we run the precaution and apply pressure injury prevent dressings. Let's move on. The second one is about management of chronic wound during COVID-19 pandemic in the Severance Hospital. I'm gonna show you about the infection prevention rules that I'm working on in Severance Hospital. Severance Hospital is one of the largest hospitals in Korea. We have 3,000 hospitalized patients and more than 4,000 outpatients a day. Several hospitals doesn't treat mild illness, but can treat only severe illness. It's a high dense area, even though it's a hospital only for people with severe disease. So it's classified as a high risk area in the Korea. For patients with non-critical wounds, for example, stable ulceration, dry scalp, the general aim for wound management during the pandemic is primarily to ensure a level of wound care. It can prevent deterioration while limiting unnecessary in-person visits, minimize potential exposure to the virus for both patient and healthcare providers. Wound care community must accept that the goal is not necessary to complete ulcer healing or wound closure through this may occur. I adjusted the treatment goal of patient visiting outpatient as much as possible. The goal of treatment was adjusted from active treatment to self-dressing healing, especially for patients with pressure injury. First, we loaded the goal of the treatment and created an environment for treatment at home. The patient with a pressure injury changed the interval outpatient visits 2 or 3 months. A home care nurse of a hospital visited the patient regularly. When the complication of wound occurs, the home care nurse checked the problem first. If the complications are clear, we have taken steps to allow patients to visit or be hospitalized. In addition to using the standard practices for preventing person-to-person transmission, reducing the number of wound care visits and selecting the optimal environment for wound care help reduce exposure. There is still some risk for transmission COVID-19 from home care nurses, but with the use of personal protective equipment during care in home environment, the risk is likely less compared with other healthcare settings. We don't always restrict patients from visiting hospital like this. Once in February and once in August, we limited the number of visits by patient. When the number of infected people decreased again, we have maintained the usual system. We always check the number of infection per day. The number of infected people per day is important. We also focus on the number of infected people by region. If the number of people infected in one area is high, people in this area use the special quarantine area when they came to hospital. We postponed the patient visit if it wasn't an acute disease. No one was able to break these rules because citizens themselves have the idea that they should be careful or move more. When the patient arrives at the hospital, they should conduct a COVID-related survey at the front main door of the hospital and measure their temperature. The COVID questionnaire is texted. After completing the questionnaire, the patient will receive a QR code that allows access to a hospital. If you don't use a text message or don't receive text messages, you can use your paper questionnaire in front of the main gate. This questionnaire contains symptoms related to COVID-19 and a history of visit to hazardous area. If you go through the front door, you can measure your temperature automatically. And if you go through it, the patient will attach a sticker to their crosses. And then you should conduct same thing one more time before meeting doctor or treating. If the patient has a fever, he can get through the front door. You should separate clinical in front of the hospital. There is where you perform a COVID test. If the COVID test is negative, you can enter the hospital. If positive, the patient is taken to a COVID-related hospital. It takes about 6 hours to get the COVID test results. In reality, patients with a fever can't use a hospital on the same day. If you have an emergency symptom, you can use the emergency room after examination results have been obtained. This picture, you can see the healthcare worker in wearing PPE equipment. This is the hospital. This is the hospital cafeteria for healthcare workers. We can only use this cafeteria. Medical staff were prohibited from using cafe or the restaurants used by patients. Or lecture and meeting are being conducted by video. At Severance Hospital, only COVID patients with a severe respiratory problem are hospitalized for treatment. Even though I have had a COVID patient with chronic wounds, but I have never had the nurse take a picture of the patient and sends it to the hospital records. I can see that picture and tell the nurse how to treat it. If it is hard to take care of the wound or if you need training, I personally train nurses or have made video to provide educational materials. This is a map of Severance Hospital. Of these many buildings, only COVID patients can be admitted to the red box. It's to separate them from other patients. The most important thing is washing your hands and wear a mask. Along with this is a social distance involving all medical staff and all patients. We currently have 5 levels of guideline in Korea. The criteria depends on the number of infections per day. Depending on the stage, our activity is limited. Especially the medical staff is being applied more strictly. If the citizen apply level 1, the medical staff should keep level 1 and a half distance. I think this is not for only me, but for patients. Sometimes it is frustrating and it's just I believe that we can overcome COVID quickly. Thank you for your attention.
Okay, hello Miss Han. You can turn on your microphone.
Okay. Hi, everyone.
Okay, Miss Han, there is a nice presentations about the Teams Concept 2020. So are you ready for a Q&A session, question and answer session?
Yes.
Okay, there is a questions. Any question from Mr. Haidir Bashar from Bayangkara Hospital in Palembang, Indonesia? The questions is, there is a diabetic wound care community in your area, and what is your purpose? Then what you should be achieved? So what your the purpose of diabetic wound care community?
Yeah. Absolutely. I have a diabetic foot care treatment, so I have many patients. My purpose during pandemic, it is not high. It means my treatment is for oral cure, oral wound closure. Sometimes COVID-19 is dangerous for patient during treatment in the hospital. I said my goal is lower. So during dangerous COVID pandemic, I recommend only wound care for them. I teach them how to care wound care. But if they have a serious diabetic foot condition, we have a hospitalized amputation and vascularization, amputation, and control infection. We do all of that.
Okay, Miss. Okay, so it means the community that you made is to learn each other about the conditions, about wound care or foot care, and about daily treat, right?
Yeah, you're right.
Oke, jadi untuk di Korea sendiri di sana ada komunitas luka diabetik itu untuk mempersempit ataupun mempersempit lingkup bagaimana cara untuk pendekatannya, untuk mengajari bagaimana perawatan luka tiap harinya dan juga untuk mengenali kondisi luka, baik kronik ataupun akut. Okay, Miss. There is a next question. We are open for 5 questions for Miss Han and Jean. Okay. What's the next questions? There is the next question not yet.
I'm curious about Indonesia.
Why?
Do you have many COVID patients with chronic wounds?
Yeah, there is a lot of kind of wound in here and a lot of treatment in here, such as
Can you
modern
treat
treatment and condition.
Can you treat them by yourself directly?
Yeah, it depends on the conditions. It depends on the wound conditions. If the condition is like acute phase of wound care, and we can do treat directly. Yeah, we treat. If there is a need medical therapy in the hospital, so we can do give counseling to bring the patient to hospital.
I see.
And
I see.
in Indonesia, there is a lot of herbal medications. Herbal medication for the wound. Yeah, a lot of herbal medication. Beside the
see.
modern dressing, there is a conventional dressing and herbal dressing.
Actually, I have never met my patient with the coronavirus because we just use see the photo and recommend how to do.
Just interactive counseling, Miss, right?
Yeah, if I impacted coronavirus, another patient is dangerous, we think.
Yeah.
So we prohibit to meet COVID patient, just isolate, and some few healthcare giver give few medical staff can meet them. So I curious about Indonesia situation.
Okay, so in Korea, how about the case confirmed right now? There is increasing or decreasing about the COVID-19 case.
We usually occur 100 under 100 COVID patient per one day, so it is not much. But recently, last week, suddenly increased because of winter. Maybe temperature degree is decreased, cold, catch a cold. So we were worried now.
There is easier for COVID-19 spread because because the weather is lower more than Indonesia.
Yeah.
Okay, Miss. There is a question. There is a question from Mr. Ryan. Mr. Ryan, speaker before you. Mr. Ryan from Philippines. What if the patients have a chronic wound and has COVID and tends to be positive for a long time? Will they be treated by wound specialist or will wait to COVID is going? So there is a patient that have a chronic wound care and it also have a COVID-19 confirmed. So what they do? What to do? First time. COVID first or wound care?
If they have a serious acute wound, we have to care them aggressively. But we have never seen, we have never have that patient for a long time, and also, but we prepare already. We already prepare the situation. Some patient with a serious acute wound for a long time, we have to, so we prepare everything to care them. Example, PPE. We have isolation treatment and negative aerosols, and we have many PPE prepared, so we don't need to care about that.
Okay, so the patient still get a treatment from the nurse or the wound specialist, right?
Yeah.
And immediately with the PPE or PPE for self.
Yeah. And also isolate treatments with negative aerosol air.
Oh, negative aerosol. Okay. Okay, thank you. There is a question from Mr. Ryan Haitala. Okay, wait. I want to choose the next questions. Okay, there is an interesting question from Mr. Igede Eka Arinjaya from Indonesia. So, what the competitions that have what the competitions what nurse must have to treat the patient in there, like license that nurse have. Okay.
Pardon?
Okay, I will replay the question. what the competency that nurse have to treat the patient in there, like a license.
License?
Yes.
We have wound care. Recently, we have a certificate from wound care nurses association. It's from government, so we have to that certificate. But we don't need to have the certification. But so that's why I have a American certification of wound and tooth care nurse. Yeah.
But just a skill is enough, right? Or not?
Yes. Well, we have to train a lot for a lot. Yeah.
So in Korea, the nurse must have a wound care license to treat the patient, or not?
Sorry, sorry, pardon.
Okay, in Korea,
Mm-hmm.
in Korea, what the nurse must have to wound care license to treat
I can.
their patient in there.
I can understand. They don't need to wound care license, but wound care expert to nurse as a me. I always teach them, and we always study and research about pressure injury or some wounds. So they can, especially ICU unit, ICU nurses can treat wound care basically.
Okay. Okay, thank you, Miss Han and Jin. So I want to choose the next questions. There is interesting questions from Mr. Igede Eka Arinjaya too. So how much the salary? How much the salary nurse, wound care nurse in Korea?
How many people?
How many salary? Salary.
How many salary? Depends on hospital. Depends on hospital.
Oh, depends on. How ranks in
Yeah,
dollar
actually
or in...
my actually my salary very personal.
Oh my god.
Yeah,
Maybe
yeah, depends on hospital, depends on their experience. Is it different, very different. For me, my salary is almost $8,000 1 year.
1 year.
Eight
Eight.
$800,000.
Okay, perhaps Mr. Igede Eka want to be Korean nurse, I think. Okay, Miss. There is the last questions from Dwesti Eka Ratnani from Vita Medica Clinic IAWHSM Jakarta. Nah,
How
the
many?
question is from Jakarta. Yeah. The question is regarding your topic about mask and 95 pressure injury. Is there any prevention that nurse can use to reduce the injury, or can we use like petroleum jelly or mineral oil? Thank you.
Yeah, it is a good idea. It is a good idea because they say first care your skin.
Yes.
So dry up and protect some moisturizer. So petroleum jelly or mineral oil also can protect my skin. So you can use. But if you want apply prophylactic dressing, petroleum jelly or mineral oil can attach that prophylactic dressing. So you have to choose petroleum jelly or mineral oil or prophylactic dressing. Both are okay.
So what the most effectively, petroleum jelly or mineral oil?
What is better? Petroleum jelly can little bit. Petroleum jelly is better because they can make some seal with N95 mask.
Okay, I think enough. There is a 5 question finish. To Mr. Han Anjin from Korea. Okay, Miss Han Anjin, thank you for sharing with us about your material, your nice material today. And before it, I want to give all audience the closing statement from you.
Sorry, I can hear you. Can you repeat that?
Could you give a closing statement for all audience? Closing statement. Okay. Okay, don't worry. Okay, thank you for taking time. Okay, for your taking time. I think your schedule is very busy, so very thank you for your taking time with us and all audience.
Yeah, thank you.
Thank you. And for the last, thank you very much, Mr. Han Anjin from Korea.
Yeah, thank you. Bye.
Bye. Oke, untuk seluruh audiens yang berbahagia, dilanjutkan untuk pemateri yang ketiga. Sebelumnya saya mau sapa dulu untuk pemateri yang ketiga, Bapak Asmat Burhan. Assalamualaikum Bapak. Bapak Asmat Burhan. Sebelumnya saya tawarkan dulu mau menyampaikan materi langsung ataupun nanti digabung sama workshopnya.
Nanti digabung sama waktu aja.
Digabung sama workshopnya dulu.
Iya. Break dulu ya.
Iya, terima kasih Bapak. Oke, terima kasih untuk seluruh audiens karena dikarenakan Pak Asmat Burhannya berkenan untuk menyampaikan materi barengan sama workshopnya. Jadi untuk acara seminar kali ini kita langsung break dulu sekitar 1 jam. Sekarang pukul 10:30, 10.30. Nanti kita kembali lagi join di line Zoom-nya pukul 11:30. Nanti kembali lagi di pukul 11:30 di Zoom ini ya. Terima kasih.
Sik batu manikam di para joget sor marikotam dina mangingani si Bambang Karjula si Bambang Karjula. Sik batu manikam di para joget sor marikotam dina manginani si Bambang Karjula si Bambang Karjula. Sik si batu manikam di par joget sor marigotam dina manginani si Bambang Karjula si Bambang Karjula.
Rasa sayangi lihat dari jauh. Rasa sayangi rasa sayangi lihat dari jauh. Rasa sayangi. Kalau ada sumur di ladang, boleh kita menumpang mandi. Kalau ada umurku panjang, boleh kita jumpa lagi. Kalau ada sumur di ladang, boleh kita menumpang mandi. Kalau ada umurku panjang, boleh kita jumpa lagi.
Rasa sayangi, lihat dari jauh. Rasa sayangi. Bungong jembah mekar di Aceh. Bungong ngapung luhur jauh di awang-awang, mau berkencang jana bangun daya karingrang.
Sungku narang daun seceng pamatung nangelu, ngapak mega bari pernah tarik dulu.
Saha anu bisa nyusuk kana tandangna, kandang jeng pertental daya pandinganana.
Dipika gini dipika senap kusa sama, daya karembang kasih lebih mamanena. Mano dadali, mano banggagana, terlambang sakti Indonesia Jaya. Manuk dadali, bangga koncarana, resepna hiji, rukun sakabena. Re ayo re, mlaku-mlaku nang tunjungan. Re ayo re, rame-rame bebarengan. Cak ayo cak, sopo kudu melu aku. Cak ayo cak, boleh kenalan cak ayu.
Ngalor ngidul liwat teko ngumba moto, masih yang nyengkal-nyengkal hati leko.
Sopo ngerti nasib awak lagi muncul, kenal anak sing dodol rujak ampar-ampar pisang, pisangku baru masak, masak sabigi di hurung bari-bari, masak sabigi di hurung bari-bari. Mangga lepak, mangga lepok, patah kayu bengkok, bengkok dimakan api, apinya cangcurupan. Bengkok dimakan api, apinya cangcurupan. Nang mana batis kutung, dikiti bidawang. Nang mana batis kutung, dikiti bidawang.
Sajojo, sajojo, yung orang koi sebab para samuna-muna-muna keke, samuna-muna-muna keke. Sajojo, sajojo, yung orang koi sebab para samuna-muna-muna keke, samuna-muna-muna keke. keling manuk cingklang cendatan, loloskan kolam bapak satan ulatan. Mendaki jalan pandai sike, menurun jalan ke biaro, ima hati indah mampe, awan kaki cuan, oi oi, ayam delape. Layang-layang, selayar pandang, hati di dalam, bagai bergoncang. Jangan ragu dan jangan bimbang, ini lagu selayar pandang. Gandang garam tu, hayat dengan kangkanu, sambil tuntang gang tahu, biar mundur dan maju. Ayo mandari manasai, mandari manasai, mandari manasai. Belenggang patah-patah, nganape goyang pijak-pijak, nganape body bocok-bocok. Tenggang-tenggang lopi na anak koda ipan jajah buluana. Pinang muda dibelah dua, gunung kerinci, gunung yang tinggi menjulang. Wahai anak muda, kalau berjalan harus berdua, senanglah hati walau tiada orang yang larang. Jantung hati Tuhan ada di kampung baru. Hey hey, Caca Marica, hey hey, Caca Marica ada di kampung baru. Caca Marica, hey hey, Caca Marica, hey hey, Caca Marica ada di kampung baru. Ayah mama, cucu mama para beta, dia cuma pegang beta. Ayah mama, jangan mama. Orang muda punya biasa, orang muda closer to the dark. Hide away, they say, 'cause we don't want your broken parts. I learned to be ashamed of all my scars. Run away, they say, no one loved you as you are. But won't let them break me down to dust. I know that there's a place for us, for we are glorious. When the sharpest words wanna cut me down, I'm gonna stand afloat, gonna drown them out. I am brave, I am bruised, I am who I'm meant to be. This is me. Look out, 'cause here I come. And I'm marching on to the beat I drum. I'm not scared to be seen. I'll make no apologies. This is me. Another round of bullets in my skin. Well, far away. Today, I won't let the shame in. We are bursting through the barricades and reaching for the sun. We are warriors, and that's what we become. Won't let them break me down to dust. I know that there's a place for us, for we're glorious. When the sharpest word wanna cut me down, I'm gonna stand afloat, gonna drown them out. I am brave, I am bruised, I am who I'm meant to be. This is me. Look out, 'cause here I come. And I'm marching on to the beat I drum. I'm not scared to be seen. I make no apologies. This is me. This is me. When the sharpest words wanna cut me down, I'm gonna stand afloat, gonna drown them out. This is brave, this is bruised, this is who I'm meant to be. This is me. Look out, 'cause here I come. And I'm marching on to the beat I drum. I'm not scared to be seen. I make no apologies. This is me. This is me. This is me. I'm trying to hold my breath, let it stay this way. Can't let this moment end. You set off a dream in me, getting louder now. Can you hear it echoing? Take my hand, will you share this with me? 'Cause darling, without you the shine of 1,000 spotlights, all the stars we steal from the night sky will never be enough, never be enough. Towers of gold are still too little. These hands could hold the world, but it'll never be enough, never be enough for me. Never, 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 never for me, for me. Never enough, never enough, never enough for me, for me, for me. All the shine of 1,000 spotlights, all the stars we steal from the night sky will never be enough, never be enough. Towers of gold are still too little. These hands could hold the world, but it'll never be enough, never be
Kapan terakhir kali kamu dapat tertidur tenang? Tak perlu memikirkan tentang apa yang akan datang di esok hari. Tubuh yang berpatah hati bergantung pada gaji, berlomba jadi asri, mengais validasi. Dan aku pun tak hadir, seakan paling mahir menenangkan dirimu yang merasa terpinggirkan. Dunia tak pernah adil, kita semua gagal. Angkat minumanmu, bersedih bersama-sama. Sia-sia pada akhirnya putus asa, terekam benih semua. Masalahnya lebih dari yang secukupnya. Rekam gambar dirimu yang terabadikan bertahun silam. Putra-putri sakit hati, ayah ibu sendiri, komitmen lama mati, hubungan yang menyepi. Wisata masa lalu, kau hanya merindu, mencari pelarian dari pengabdian yang terbakar sirna, mengapur berdebu. Kita semua gagal, ambil sedikit tisu, bersedihlah secukupnya. Secukupnya, kan masih ada penggantinya. Belum waktunya kau bisa menjawabnya. Secukupnya, wayang sirna kan kembali lagi. Semua yang sirna
arms wide open behind these four walls, hoping you come. It's just a cruel existence, like it's no point hoping at all. Baby, baby, I feel crazy all night and every day. Give me something, oh, but you say nothing. What is happening to me? I don't wanna live forever, 'cause I know I've been living in vain. And I don't wanna fit wherever. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back home.
I'm sitting eyes wide open and I got one thing stuck in my mind. Wondering if I dodged a bullet or just lost the love of my life. Oh, baby, baby, I feel crazy up all night and every day. I gave you something, but you gave me nothing. What is happening to me?
I don't wanna live forever, 'cause I know I've been living in vain. And I don't wanna fit wherever. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back
I've
home.
been looking sad in all the nicest places.
Baby, baby, I feel crazy
I see you around in all these empty faces.
all night and every day.
I've been looking sad in all the nicest places.
Give me something, oh, but you say nothing.
Now I'm in a cab, I tell them where your place is. What is happening to me?
I don't wanna live forever, 'cause I know I've been living in vain. And I don't wanna fit wherever. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back home. I just wanna keep calling your name until you come back home.
I just wanna keep calling your name.
Until you come back home.
Till you come back home.
Climb on board. We'll go slow and high tempo, light and dark. Hold me hard and mellow. I'm seeing the pain, seeing the pleasure. Nobody but you, body but me, body but us, bodies together. I love to hold you close tonight and always. I love to wake up next to you. I love to hold you close tonight and always. I love to wake up next to you. So we'll piss off the neighbors in the place that feels the tears, the place you lose your fears, yeah, reckless behavior, a place that is so pure, so dirty and raw. In the better day, better day, better day, fucking It's a paradise and it's a war zone. It's a paradise and it's a war zone. Pillow talk, my enemy, my ally. Prisoners, then we're free. It's a thin line. I'm seeing the pain, seeing the pleasure. Nobody but you, body but me, body but us, bodies together. I love to hold you close tonight and always. I love to wake up next to you. So we'll piss off the neighbors in the place that feels the tears, the place you lose your fears, yeah. Reckless behavior, a place that is so pure, so dirty and wrong. In the bed all day, bed all day, bed all day, fucking and fighting on. It's a paradise and it's a war zone. It's a paradise and it's a war zone. Paradise, 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 war zone, war zone, war zone, paradise, 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 war zone, war zone, war zone, war zone. So we'll piss off the neighbors in the place that feels the tears, the place you lose your fears, yeah. Reckless behavior, a place that is so pure, so dirty and wrong. In the bed all day, bed all day, bed all day, fucking and fighting on. It's a paradise and it's a war zone. It's a paradise and it's a war zone. Help me. It's like the walls are caving in. Sometimes I feel like giving up, but I just can't. It isn't in my blood. Laying on the bathroom floor, feeling nothing. I'm overwhelmed and insecure. Give me something I could take to ease my mind slowly. Just have a drink and you'll feel better. Just take her home and you'll feel better. Keep telling me that it gets better. Does it ever? Help me. It's like the walls are caving in. Sometimes I feel like giving up. No medicine is strong enough. Someone help me. I'm crawling in my skin. Sometimes I feel like giving up, but I just can't. It isn't in my blood. It isn't in my blood. I'm looking through my phone again, feeling anxious, afraid to be alone again. I hate this. I'm trying to find a way to chill. Can't breathe, oh. Is there somebody who could help me? It's like the walls are caving in. Sometimes I feel like giving up. No medicine is strong enough. Someone help me. I'm crawling in my skin. Sometimes I feel like giving up, but I just can't. It isn't in my blood. It isn't in my blood. I need somebody now. I need somebody now. Someone to help me out. I need somebody now. Help me. It's like the walls are caving in. Sometimes I feel like giving up, but I just can't. It isn't in my blood. It isn't in my blood.
putting makeup on my cheeks. Do what I want. Love every single part of my body, top to the bottom. I'm not a supermodel from a magazine. I'm okay with not being perfect, 'cause that's perfect to me. 'Cause that's perfect to me. 'Cause that's perfect to me. No matter where I go, everybody stares at me. Not into fancy clothes, I'm rocking baggy jeans. Getting too close for comfort, but comfort is what I need. So I eat my body weight in chocolate and ice cream. Maybe I bite my nails and don't think before I speak. Don't fit in any crowd, don't ever get much sleep. I wish my legs were bigger, bigger than New York City. And I love who I want to love, 'cause this love is gender free. Don't feel like putting makeup on my cheeks. Do what I want. Love every single part of my body, top to the bottom. I'm not a supermodel from a magazine. No, I'm okay with not being perfect, 'cause that's perfect to me. 'Cause that's perfect to me. 'Cause that's perfect to me. Sometimes I wake up late and don't even brush my teeth. Just wanna stuff my face with leftover mac and cheese. You know I get depressed, are you impressed with my honesty? Still I wear what I wanna, 'cause I'm cool with what's underneath. I wanna kiss someone that I'll never see again. I wanna go somewhere, go there with all my friends. I wanna take my family to go and see Eminem, 'cause my sister's been in love with him since like we were 10. Don't feel like putting makeup on my cheeks. Do what I want. Love every single part of my body, top to the bottom. I'm not a supermodel from a magazine. I'm okay with not being perfect, 'cause that's perfect to me. 'Cause that's perfect to me. 'Cause that's perfect to me. That's perfect to me. Yeah, that's perfect to me. Meet you where you been. I could show you incredible things. Magic, madness, heaven, sin. Saw you there and I thought, oh my God, look at that face. You look like my next mistake. Love's a game, wanna play. New money, suit and tie. I can read you like a magazine. Ain't it funny? Rumors fly. And I know you heard about me, so hey, let's be friends. I'm dying to see how this one ends. Grab your passport and my hand. I can make the bad guys good for a weekend. So it's gonna be forever, or it's gonna go down in flames. You can tell me when it's over, if the high was worth the pain. Got a long list of ex-lovers, they'll tell you I'm insane. 'Cause you know I love the players, and you love the game. 'Cause we're young and we're reckless, we'll take this way too far. It'll leave you breathless, or with a nasty scar. Got a long list of ex-lovers, they'll tell you I'm insane. But I got a blank space, baby, and I'll write your name. Cherry lips, crystal skies. I could show you incredible things. Stolen kisses, pretty lies. You're the king, baby, I'm your queen. Find out what you want, be that girl for a month. Wait the is yet to come. Oh no, screaming, crying, perfect storms. I can make all the tables turn. Rose garden filled with thorns. Keep you second guessing like, oh my God, who is she? I get drunk on jealousy, but you'll come back each time you leave. Cause darling, I'm a nightmare dressed like a daydream. So it's gonna be forever, or it's gonna go down in flames. You can tell me when it's over, if the high was worth the pain. Got a long list of ex-lovers, they'll tell you I'm insane. Cause you know I love the players, and you love the game. Cause we're young and we're reckless, we'll take this way too far. It'll leave you breathless, or with a nasty scar. Got a long list of ex-lovers, they'll tell you I'm insane. But I've got a blank space, baby, and I'll write your name. Boys only want love if it's torture. Don't say I didn't warn ya. Boys only want love if it's torture. Don't say I didn't warn ya. So it's gonna be forever, or it's gonna go down in flames. You can tell me when it's over. If the high was worth the pain. Got a long list of ex-lovers, they'll tell you I'm insane. Cause you know I love the players, and you love the game. Cause we're young and we're reckless, they'll take this way too far. It'll leave you breathless, or with a nasty scar. Got a long list of ex-lovers, they'll tell you I'm insane. But I've got a blank space, baby, and I'll write your name. I've been hearing symphonies. Before all I heard was silence. A rap. I've been hearing symphonies. Before all I heard was silence. A rhapsody for you and me. And every melody is timeless. Life was stringing me along. Then you came and you cut me loose. Was solo singing on my own. Now I can't find a key without you. And now your song is on repeat, and I'm dancing on to your heartbeat. And when you're gone, I feel incomplete. So if you want the truth, I just wanna be part of your symphony. We hold me tight and not let go. Symphony, like a love song on the radio. We hold me tight and not let go. I'm sorry if it's all too much, but every day you're here, I'm healing. And I was running out of love,
Ngani udan. Emang mau itu. Assalamualaikum Pak Asmat.
Waalaikumsalam warahmatullahi wabarakatuh.
Gimana kabarnya Pak Asmat?
Alhamdulillah di sini mendung ya.
Oh iya Pak, ini nanti untuk penyampaian materinya apa langsung sama workshopnya dulu atau materi dulu?
Kita materi dulu, setelah materi nanti akan ada 2 video workshop. Tidak, untuk materinya mungkin sekitar 45 menit, kalau untuk workshopnya mungkin sekitar setengah jam ya.
Sebentar ya Pak, di sini masih azan.
Oke, didahuluin dulu.
Iya.
Masih di mood itu, Mbak. Masih di mood.
Ya, Pak, lupa, Pak. Oke. Assalamualaikum warahmatullahi wabarakatuh. Saya ucapkan kembali bergabung kepada seluruh audiens untuk mengikuti proses selanjutnya, yaitu sisa materi terakhir dan juga langsung lanjut di sesi workshop. Nah, ini masih ada materi dari Bapak Asmat Burhan. Nah, kemarin kan sudah menyampaikan materinya, dan ini yang kedua. Jadi, mungkin teman-teman audien masih ingat ya untuk CV-nya Bapak Asmat Burhan. Untuk Bapak Asmat Burhan sendiri, Food Care Nurse, Internasional Therapist Nurse, CEO Global Indonesia Healthcare Foundations, Director of IAWHSM Center, researcher with 7 research results and 3 international journals. So, in this opportunity, he will be sharing her expertise on infection control about protocol and management in wound care part 2. Oke, halo Bapak Asmat Burhan. Sudah siap ya Pak untuk menyampaikan materinya? Mungkin mau disapa dulu untuk audiennya, karena ini sudah siang. Mau disapa dulu Pak untuk audiensnya.
Oke, how are you, partisipan? Are you ready? Okay. I think participant ready all.
Yeah.
Workshop.
It's ready for workshop. Oke, silakan Bapak Asmat Burhan.
Bisa ambil alih ya. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin, umuri dunya waddin, sholatu wassalamu ala asrofil anbiya'i wal mursalin wa ala alihi wa sahbihi ajmain. Okay, welcome to the second day International Asean Science Multidiscipline. Today, special thanks for the committee, the opportunity sharing the workshop today. Okay, my topic in the workshop today, diabetic food exam, the times, concept, and diabetic food care management. This is the collaboration for the Internasional Food Care Nursing, International Nursing, Nursing Hospital, 7 USA Health System, Seoul, South Korea, and the Consultant Wound Care Unit Clinic, Kediri, Indonesia, the conference. Okay, direct to the topic. My outline, introduction, food screening, assessment and diagnosis, diabetes-related history, food assessment, foodware assessment, and education needs for the patient, initial assessment for the food, and right stratification for the future for the patient, and the conclusion. The food screening, recognition as the modality to identify those at low current rates or at rates of the ulceration. Recognition as the modality to identify investigation for the examination low current or the increased rise, high rise, the ulcer. Okay, the diabetic food screening maybe is the standard to find patient at risk of the comorbidities and after appropriate advice to assess service in timely and effective manner. This is the timely the service, the prevention of diabetic foot ulcer, of the foot ulcer. This is the pressure ulcer for the pressure ulcer and the decubitus for the pressure ulcer. This is the pressure ulcer with the plantar. It's the friction, the cause from the friction of shear. This is the service, the timely, the effective of manner, and the less invalid for the people in the diabetes to assess. how the condition has affected his health health. Okay, the food screening, the people diabetes is the condition affected realities. For the condition now is the food screening, so that prevention is the application for the patient, the prevention in the ulcer. Okay, the way to screening and the health professional in the food screening, the primary care patient, because the physician or the psychology is the patient for the depression, yes, from the cost, the economy, the disease, is the patient and the depression and the stress for the disease and the cost economy family. A job is the chance for the care the patient family. Okay, the podiatrics to the food screening, and nurse too again, and also nurse the management for screening, and nurse too again for the management wound care, and nurse from the diabetic food screening the same. Okay, and the medical assistant for the assistant you, the nurse of the pediatric or endocrinologist, internist or the vascular surgeon. Okay, this you the help, you're the very help the assistant, and endocrinologist so you're the referral to the patient. This is the problem, you're the wound care or the diabetic food screening. The management is the problem. The issue of the referral from the endocrinologist. Okay, you understand for the point, the healthcare professional. Okay, the one diabetes related history, 1 minute. Type of diabetes. The diabetes is the many type, and the type of diabetes 1, diabetes in the genetic, and the type of diabetes 2, the lifestyle and the poor nutrition, and the diabetes gestational, then diabetes for the cost treatment. Okay, and the of diagnosis and duration for the chronic one. Yeah, because the chronic wound management, if one care and 2 weeks, not the result for the progress, the wound healing. 1 point remember, and the 1 point important, duration to reduce. Okay, and to reduce for the chronic one, and treatment to the referral for the paramedics or the doctor, to the collaboration for the culture or the treatment for the oral, for the medication, the treatment for the non-invasive the collaboration for the endocrinologist or the vascular surgeon is the hospital And heavy 1C person onset on the wound in the death taken. Heavy C1 C person, this is the gift for the healing. This is the heavy C1C, the 10% and abnormal. This is the problem, you're the healing the food ulcer. Okay, and status of retinopathy, neuropathy, and cardiovascular disease. With the status, the assessment the documentation, and this is the retinopathy, this one the neuropathy for the vascular and the cardiovascular. This is the collaboration for the doctor. And the smoking status, yes, smoking status before you have the problem of the vascular, the arteriosclerosis. Okay, the occupation, previous food ulcer, and previous vascular and previous amputation for the documentation for you. Related history, the patient. Okay. Because related history, you success, the documentation result to the healing and the success. to address the potential cure and the status of developing diabetic foot problem. Foot assessment, 1 minute. Neurologic, vascular, dermatological, and musculoskeletal. Neurological examination, the screening for peripheral neuropathy. There is the light tube, pin prick, monofilamentized vibration tuning fork, and proprioception. Light tube. Light tube does the feel, the sensation for the patient. Application the carton or the gauze to feel neuroplants very fair for the patient. Okay, the picture A, the picture 1, light tube. Thus, the feel sensation for the patient. Okay, and the print pick, the same with like the light tube, but different feel sensation with the application sensation pain. This is the question. Does the feel the patient and sensation for the pain in the toes from the foot patient? Very well. Okay, next. Monofilament test, the supporting investigation or the examination of the plantar neuro for 9 locations from foot with the application yarn 1 gram with the patient closed eyes. Okay, supporting investigation the plantar neuro for the 9 location for the plantar foot, and with the application yarn 1 gram and with the patient close my eyes. Okay, you understand? Okay. And for the same is monofilament test the diffraction tool frog and the touch feeling about the sensation for the patient. And the tuning fork the same, the monofilament test, different tool, fork, and the vibration is the tool. Okay, tool the vibration for the it's Thus feel the sensation patient with the vibration. Okay, it's the vibration, the vibration for the same the foot is the sensation for the vibration for the foot in peripheral. Okay, next pre-operation. Okay, do the observation for this patient. Okay, the question, the test to talk or any fungal or the infection for the foot. Ya, ada jamur atau ada infeksi atau kering pada kakinya seperti itu ya. Okay, neurological examination, numbness. There is the patient the activities day to day. There is the feeling in the plantar foot, numbness, and the burning sensation, and the pricking feeling, and able to sense of it willing the walking the patient. This is the patient, this is the sign and symptom to the neurological examination. For the question for the patient. The vascular the examination, screening for the peripheral artery disease. Check for the dorsalis pedis pulse, posterior tibial pulse, and the popliteal pulse, change in the skin color, and the change of the skin temperature gradient and the capillary refill. Okay, this is the vascular, that's the color the change in foot. The patient does feel the increased temperature for the patient, hot or the cold, due to investigation, examination, capillary, or the Indonesia GRT, to the knowing vascular peripheral patient, to the problem is the circulation peripheral patient foot. Okay, this is the ankle brachial index pressure. The ankle brachial index pressure take a blood, the compression with the cuff in both arms, and add around lower leg using a Doppler problem. High calf pressure at weight pulse can be heard like blood pressure, arm blood pressure, ABPI, ankle brachial pressure index. Okay, this is the formulation for the ABPI. Okay, low 0.5 arterial ulcer, no bandage. Okay, and 0.5 until 0.7 mixture arterial or the venous ulcer, and 0.7 until 0.9 the same mixture ulcer or the venous ulcer. This is the 3-layer bandage, and increased 0.9 venous ulcer 4-layer bandage, and increased 1.2 the possible checklist division 5. You check again. Okay, this is the formulation for the standard operational procedure in the hospital, in the clinic, or in the private practice nursing. You the application for the practice, and you do the application from the standard compression or the ABPI. You do from the guideline application from the WCT, WHS, or the compression bandage international. Okay, and test the comparison of the blood pressure in your arms and leg to determine if you have the PAD. PAD, peripheral artery disease, and evaluate the strength of the pulse at your legs and feet. Okay, this is the formulation. This is the standard operational procedure. Up to you. You the application for the guideline for the WCET, WHS, the AWM, the compression, or the ADA from the American Diabetic Association. Up to you. This is the same, and just this the give use. They give you the protocol from the hospital, clinic, and the private practice nursing. Okay, the 3-layer bandage, 4-layer bandage is the the type of the bandage in elastic bandage, or the orthopedic wool. This is the pressure. Yeah. Okay. This is the ankle brachial pressure index to investigation following the problem, the vascular disease. Okay, venous problem or the arterial problem. Okay, this is the venous leg ulcer. Next management. How the next management? Okay, this is the evaluate the problem for the arterial ulcer. How to avoid the management the arterial ulcer. This is the different management. Okay, and the sign and symptom for the venous leg ulcer or the arterial ulcer difference, very different, significant. Okay, vascular examination, the symptom claudication, pain when walking, acute stop and relief pain. Okay, this is the walking, the patient, the diabetic for the pain in walking, and acute stop relief pain in the stop the acute for the in the house, the sleep. It's the relief pain. And rest pain in the night, dropping the legs over the side of the relief pain. This is the sign of symptom, the vascular examination. Okay, dermatological, the examination. Point C, the skin. Okay, the dry. This you look the observation for the foot patient. Okay, the foot patient, the dry. Okay, dry, shiny, hyperpigmentation. This is the change color, yeah, and hair loss hair to the toes foot, the hair loss and colors, corn, and the fissure, and the fungal infection. Okay, this is the fungal infection. With the look and your observation the condition for the food patient and your documentation for the next management for the diabetic food screening or the prevention for the food in the washing patient, okay, the food patient and the lotion for the prevention dry, shiny, and hyperpigmentation and the colors, then corn fissure to the management food spa patient, okay. To about the prevention, what? This is the high ratio, heights. I'm sorry. This to connect.
Okay. Thank you, Mr. Asmat Burhan. That is a nice presentation.
Okay. Okay. Okay.
I want to check any question or not.
Examination.
Oh.
Screening for childhood neuropathy, foot deformity, gouters, hemorrhagia, bony prominence, splenus, and the scalpels. They are the patient in this all the sign system for patient in scalpels. Okay, this is the high ratio for the pressure ulcer in the plantar foot. Okay, this is the gouters, this is the Boronians, this is the big foot. Okay, this is the musculoskeletal because foot deformity is high price. Foot wound versus the foot wound the patient, so that the election for the sandal or the soles patient, very important to prevent the pressure ulcer foot. Okay, because the patient for the very good to the prevention. Musculoskeletal examination, range of motion to the exercise for patient activity in morning or the afternoon. Yeah, the muscular strength of the dorsalis flexion and the plantar flexion, and the normal the patient active your the patient the activity is the mandatory independent of the patient and the bedrest your the passive the examination musculoskeletal room. Footwear. So evaluation is a point of the irritation or the skin breakdown related to those and bony prominence. The sole of the sole should be inspected for the exercise where the pattern, style, condition, and fit. This the patient the footwear to high risk to prevention the ulcer. This the pressure, the plantar pressure, the high ratio to the pressure ulcer. Okay, so that the style and condition and footwear assessment to the success the prevention ulcer foot. Education 1 minute. Check fit daily sites, spot alert for foot problem. Number 2 was feed daily meal salt, lukewarm water, no swacking of food. Apply lotion daily soft, smooth, not in between toes. Okay, nail care, cut carefully, 1 week, and straight across, though not too short. Okay, sock not too light color, avoid half seams, sauce cannot too tight, but sauce in the late afternoon. Adjustable straight and wet too. Exercise regular, promote good blood and circulation in the foot. What to call the foot to help the corn close a wound. The point, this lack of the diabetic foot education and risk factor awareness may be a factor in more than 90% of the recurrent ulcer. Giovinino and Miller 2019, according to journal. Okay. Initial ulcer assessment, depth of ulcer. Okay, depth of ulcer is the ulcer the occurred when that the wound Okay, reason for the visit. When the reason for visit, the management won't care for you. Okay, and the affected food, ulcer site. Okay, this the cause the diabetic foot ulcer, glucose, or the source of sandal, recurrent antibiotic, site of wound, the grinding classification, antibiotic that has you got because for the next management for the documentation antibiotic. Okay, and next appointment, the management, the sites for the healing and any referral for the or the rujukan, granting this classification. Okay, what one is the main the prevention or the primary care. For normal the care thing that is the secondary care. For spa you can give the monofilament, light and break, and the treatment will be the point the effective pregnant, control infection, internal referral surgeon, and the vascular nutrition work, the patient rehabilitation. Okay. Final point, that short to conclude the diabetic foot assessment. Next appointment. Okay. Next point assessment. Foot when there is main prevention or primary care for normal diabetic foot with the location oil, washing the feet, the cutting cords is okay, the secondary. Okay, the multidiscipline and the any referral needed multidiscipline team. Your the collaboration, the internal surgeon, endocrinologist, or the vascular surgeon. Okay, so the I help you all to the nurse in Indonesia, to the only one the professional in the management wound care, because the wound care the complexity is the factor the patient, factor the for the wound, factor for the skill for the factor the nurse or the doctor or the multidiscipline, and the factor the rising of treatment. This the many for the multidiscipline team. Okay, not only one profession. Okay, this is the footwear in the My Clinic, the F-Care module. Footwear, this is the main the prevention and primary care for the normal diabetic foot with lotion, oil, washing the feet, cutting nails is okay. It's okay. Secondary care with spa, you can give the monofilament test up to you, and the free patient, like pain break, the assessment for you, and documentation for the next management for you. This is the application for the hospital or the clinic you. And the T3R3 will be the one advanced the pregnant control, infection, internal referral surgeon, and vascular nutrition born the podiatrics and rehabilitation. Okay, this is the normal DF care, diabetic foot care, the footwear. Okay, the first, the point credential for the footwear care. The patient diabetes high risk for the foot ulcer. One, the metabolism for the problem disease. Is the metabolism disease the problem. Nutrition and the oxygen for the vascularization peripheral. Ya, tidak akan sampai di sana, sehingga akan muncul ya ulcer seperti ini. Normal DF care, PNP, PFD care, diabetic foot ulcer care, diabetic foot ischemic care, and the rehabilitation care. And for the point 1, 2, 3, 4, 5, and the point primary, secondary, and tertiary care not applying management of diabetic foot. Okay, if you there, the start way of amputation patient. Okay, and start way of the amputation patient is the deformity. Always this patient alive, the activity patient, the problem, and the stress, psychic, depression, the maybe the patient and the suicide. Okay, because the cost the economy and the family add up to the stress and depression. Okay, times and diabetic food management. The times and the diabetic food management is the management of wound in the diabetic food management. Assessment, the assessment, the holistic assessment for the etiology or the penyebab, ya, penyebabnya apa dari terjadinya luka itu. Mungkin karena dia faktor genetik, seperti pada pasien DM ya, tipe 1, atau dia faktor eksternal, mungkin karena sepatu atau sandal karena keinjak paku atau yang lain, atau memang dia dari vaskulernya sendiri seperti selulitis ya, atau phenolic ulcer. And duration of the wound, age or the usia luka. Nah, berapa panjang usianya luka itu dari dia muncul sampai sekarang, seperti itu. And the factor the impede the healing, faktor penghambat, bisa glukosanya terus meningkat, leukosinya terus meningkat, terus ada problem for the vascular vein or the artery. Jadi ini akan jadi penghambat ya. Lifestyle-nya tetap, pasiennya tidak berubah, itu akan menjadi sebuah ekosistem yang menimbulkan masalah-masalah yang penuh misteri di diabetic foot ulcer. Okay, wound assessment location, state, wound base, type of tissue, dimension, exudate, odor, wound age, peri-wound skin, site of infection, wound pain, granulation, and epithelialization wound. The wound assessment is the select available wound. When identified on the select on onset date, select the culture date, has the patient been identified? Yes, this is the location, the draw location for the wound patient and foot. Okay, this is the documentation for you. Next step or day by day patient the progress for the wound healing. This is the success management and wound healing the future. Okay, this is the problem, the evaluation for why wound care me. The problem is the wound healing. The evaluation is the draw the wound. Okay. Okay, location 1 is the Vitus-Jensen assessment, or the Vitus-Jensen instrument for the Vitus-Jensen to the progress wound healing. This is the size 1, the stake, wound age, undermining, the tip exudate, the ferry exudate, the color, the peri-wound skin, jarring up. This is the edema or them, granulation, and epithelialization. Okay. Okay, I explain for you to the point 1 for 10. Go to the commentation. This is the very, very important to the progress in patient, and also to the documentation for patient for you. Size 1. Size 1, the important for documentation and the progress step-by-step care. Because the size 1 is the day to day, this one the 3 centimeter, and for 2 weeks you 2 weeks 4 weeks you difference yeah, for the comparison for the 1 week and 4 weeks evaluation for the wound. Does the wound progress or not progress then wound healing? Okay, when you the wound not progress evaluation for you management wound care. Okay, when states the crowing you for the investigation or examination wound stadium 1, 2, 3, 4 to the application rising and stakes. Okay. Stake 1, epidermis, stake 2, dermis, stake 3, hypodermis, and for the tendon, your look, observation of the tendon, and also the application dressing. Wound edge, the peri-wound skin, okay, wound edge, the wound base, and the skin, you're the converted, okay. Knowing the condition of the wound, wound edge converted among skin and the wound base, this will show the condition, progress the granulation or the get low, increase it or the get low the granulation, okay. Undermining, knowing the investigation and the management rising, selection, election, because the undermining, if there can the management have give the expansion wound, okay, not the problem, the very the assessment for the undermining, you the have give the expansion wound, the infection, biofilm, odor, and slow, do the safe documentation for you, the patient, and the exudate, type exudate, and the knowing exudate purely, the serinios or the blood or the serous myosa or serous, for not yet serious, okay. The knowing the infection or the application dressing election, so that for example form, alginate, to the absorbent, to the exudate, or the exudate is the high moist to the wound base. This the cause the wound delayed healing, because the maturation for the wound base, okay. Volume exudate or the fallway, dry the moist, low height for the election for the absent exudate. The same the volume exudate and the tip exudate, with the next management for the according selection the dressing, okay. Peri-wound skin to the change of color, the hypigmentation, okay, the green or the red, this is the infection, inflammation for the peri-wound skin. You have the documentation, you have the documentation your patient view, and would color for the counting the normal hyperpigmentation and this management, the prevention this edema, very important. Yes, to diagnosis, investigating patient, the problem, vascular fine or the vascular, the arterial. To reduce edema for the leaking the plasma and the solve the application fixation compression bandage. This is the how the evaluate to the problem of edema for the problem in the vascular vein or the arteria. You use the examination for the ABPI with the following the 0.5, 0.5 until 0.7. This is the formulation for the ABPI, the compression bandage, okay? The 4-layer, when to the application, the 2-layer bandage, and when you to application, the 4-layer bandage. This is the protocol standard operational procedure. Up to you, important, the application, the guideline for the compression bandage. Granulation, ESC, model 2, the application support for the granulation, how the granulation 25 to 50% or the 75% or the 100%, and the epithelialization to management vascular support the epithelialization dressing. This is the one the granulation, how to the dressing application for the alginate, for the aquation agent, or the infection management control for the support the wound delay and healing, and the epithelialization agent, the collagen or the honey, or the height the growth, height the support the epithelialization. Okay, this is the assessment item, the size, stakes, undermining, exudate, failure, and the check for the scheme, edema, calculation, and visualization, the assessment. This is the result, and this for the assessment of participation 334. Result, the status condition 1, the 34, the 12, and the 5 was 7 point for the 1. Ya. Jadi kalau dibulatkan bisa selama 7 minggu di perawatan luka melahirkan kesembuhan yang signifikan. Tapi ini juga dijelaskan akan ada variabel tidak terduga jika benar-benar tidak di screening glukosa, vaskuler. Biasanya pada pasien-pasien diabetik ini sangat riskan dan harus memang benar-benar dikuasai ya tentang diabetic foot ulcer, tidak hanya dari perawatan lukanya aja, tapi juga dari info pemeriksaan penunjangnya ya, harus benar-benar point 1. Nilai prediction 55, 50-50, 50-50, nilai stroke tertinggi, rentan sakit, 12 prediksi penyembuhan, skor nilai, hasil prediksi waktu, jadinya sekitar 8 minggu pasien akan mengalami perubahan yang signifikan pada wound base and wound healingnya. Okay? This is the times concept management, IALO 2015. Okay. Okay, explain for you about the times concept here. The debilitus tissue focus clean of the tissue of exudate. Why? The debridement, action the debridement and enzymatic. From the enzymatic, the debridement, but if they use the surgical or maggot or corresponding protocol from the hospital or the private practice or the clinic. Okay, not only one. Outcome, a wound color red surface in wound base. Okay, explain for you again. Focus the definitive tissue. You focus the grain of the tissue in the wound base, necrotic or slug. Okay, or the exudate. You focus clean. Okay, until to you wound base right. Okay, action. You up to you the management of the debridement, autolytic, enzymatic, maggot, or the surgical debridement or the hydropressure. Yeah, the issue of give you the corresponding the protocol in hospital, in clinic, or in the private practice or puskesmas ya. Kalau yang bukan dari puskesmas. Outcome is red wound surface or the wound color red surface in rod base. Okay. Number 2, infection and inflammation control. Okay. Focus infection control and register inflammation. Action. Okay. Antimicrobial. Antimicrobial is the fantastic. Okay. But use the can get the 24 hours. Same 72 hours. Okay. 3 days. This is the antimicrobial you using the patient for you. Okay. Same. Okay. Infection control. Antimicrobial for to the reduce infection and inflammation. Okay. And the cleansing, you the behind the application behind the wound cleansing, because the wound cleansing, the refashion to reduce the inflammation in the biofilm to the wound base. Okay, this is the one. You the cleansing to reduce the biofilm. Okay, and infection you to use antimicrobial. This is the example cardiac iodine. The leads of the 72 horse, okay, to the activity, to the food in the bacteria or the plankton for the biofilm, or the biofilm contamination, clinical contamination, critical colonization, and spread the ischemic. Okay, the moisture balance. Moisture balance, the wound moisture balance. There is the control exudate and rising. Okay, outcome growth granulation. Because according the following journal, when the in-month condition will stimulate the formation of the fibrinogen and the angiogenesis, that granulation tissue can be formed. The choice of the dressing at this time is the important for wound healing outcome. Okay, this is the condition. This is the condition. The moist the wound. There is the high. Okay, the increase of the formation of the fibrinogen and the angiogenesis for the high granulation for the epithelialization for the wound. Okay, this is the point one. Remember, there's the application for the wound healing. Okay, the choice of dressing and is the important for wound healing. This is the outcome, the chronic granulation, control exudate and dressing. Now, the condition dry, how about the application management? And the dry condition for wound, how about application on the management in the dry and wound base? Okay. Epithelialization, assessment, and environment. Crown your skin, focus, and the action, protection, wound edge, and rising you. And the outcome your skin from the edge of the wound. And the support, the focus, support, systemic knowledge, action, education, nutrition, fixation, and the psychosocial. Plus, okay, this is the timers in the 2019. This is the formulation, the concept, new concept is the timers. Okay, this outcome the support system. Because the education patient will the patient condition, the patient will cooperative. Okay, and nutrition very important, the healing the internist from the vascular or the peripheral patient. The fixation to know the vascular and preventing infection. Okay, this is fixation. There is the prevention and the reduce to leaking from the vascular vein and increase it for the healing wound. Okay, the fixation and the prevention of the extrinsic infection. Okay. Application concept times the cooperation benefits. Very nice. This is the documentation for the my friend, pediscap, the venous leg ulcer for diabetes and EPI. This is the autolysis, the Brightman, metcopacin, and cardiac iodine. And the metcopacin plus cardiac inflammation, moist the metcopacin plus cardiac syntact, and epithelialization will edge support the reduced smoking 3-layer bandits nutrition. Okay, the APBI, the following the 0.18. Okay, the control biofilm inflammation, the polymethyl hexaminoate, and the moist metcopacin and cotimate gel, the wound edge, reduce smoking 3-layer bandits. Very nice direction of the foot care healing. This is the case. This is the 1, 2, 3. You are the control hypergranulation. Okay. This is the 1, 2, 3, 4. This 1, 2, 3. This is the 3-layer bandits. 100% healing in the 6 weeks. Okay. This is the 3 weeks or the 6 weeks. The control biofilm. This is the biofilm is the wound base. Not yet done to the wound healing, delayed wound healing. Okay, this is the very important untuk manajemen infection control pada pasien-pasien dengan ada luka. Ya. Okay. Clinical case, my patient, phenolic ulcer. This is the phenolic ulcer, 1, 3 weeks, 2 weeks, 3 weeks, 4 weeks. Yeah, this is the nice concept. The acting for the wound care. Okay, this the patient slough, erythema, otem. This the patient the second significant the infection. Okay, the leukocyte the increase because the application went to the dry application dressing and went to application management on the okay, I'm sorry. Internet loss. Okay, and 18 weeks wound care is the result. Nice for the foot. Okay, venous leg ulcer. Of course, impossible, but the wound care management is complex. In the very important to management infection control and the election for the dressing. Wound healing not impossible. Okay, this is the clinical my patient too. Diabetic foot ulcer. This is the patient the midfoot. Okay, this is the osteomyelitis. This is the post-operative patient. Weak wound care. This is the closure wound. Okay, this is the clinical case 3. Hand foot patient, diabetic foot ulcer, hand foot. 10 weeks wound care. This is the dynamic wound management. You have to control the slough, necrotic, the fragment remove, and control infection, biofilm. 8 weeks, the very nice, the closure, very impossible. The clinical case, 2 weeks. This is the forefoot. This is the towards the foot patient. Osteomyelitis. This is the post the amputation. Okay. This 12 weeks wound care. My patient is the nice. The closure for the patient. Clinical case for the same. The patient of the post amputation toes in the forefoot and the aqueous wound care and the management for the stable glucose patient and the fixation nutrition. This is the aqueous patient the closure. And remember, this is the mystery. You're the application to the foot spa patient and the referral for the again for the patient endocrine for the oral treatment. Okay, thank you for your attention. And the next video for the workshop, diabetic wound for the chronic wounds in the again. And thank you for your attention. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih untuk Pak Burhan atas materinya tentang DIMS konsep dan juga manajemen of wound care. Oh iya Pak, ini selanjutnya kita akan langsung sesi talkshow dulu ya. Dan ini sudah ada beberapa pertanyaan dari audiens. Sebentar. Pertanyaan pertama ya Pak ya, dari Kalimantan Tengah. Menanyakan, ada beberapa pasien diabetes mellitus yang sudah lama namun tidak memiliki luka atau lukanya mudah sembuh, atau satu orang ini menyebutnya penyakit gula kering. Nah, mohon penjelasannya untuk hal ini. Yang kedua, ada beberapa pasien yang saya temui tiba-tiba muncul seperti bisul tanpa sebab, padahal saat dicek gula darahnya dalam batas normal. Terima kasih. Gimana Pak, sudah jelas ya untuk pertanyaannya?
Oke, very good question ya. Pertanyaannya variabel-variabel tertentu yang tidak pernah terfikirkan muncul seperti itu ya. Oke, yang pertama diabetes kering ya. Kita kalau mencoba mengerti dari pasien yang awam itu ada dua. Untuk luka itu ada dua diabetes ya. Ada vaskulernya yang kena, ada neuronya yang kena. Ketika dia gangguan pada neuronya, dia akan cuma mengalami nutrisi metabolismenya dia akan kering. Maksudnya dalam kering nutrisi dan oksigen ataupun yang sel darah merah yang terkandung di vaskuler itu tidak akan tercerna semua karena memang ada problem di vaskulernya dari glukosanya tadi. Sehingga nutrisi yang harusnya sampai kepada perifer dan pada organ-organ yang lain, dia terjadi penghambatan di sana, sehingga dia terjadi kekeringan atau kurus ya, lemak itu nggak sampai keluar seperti itu, sehingga dia terjadi kurus atau dari obesitas tiba-tiba dia turun berat badannya kurang dari ideal kayak gitu. Terus dia tidak terjadi luka, memang belum terjadi luka karena memang sistemnya masih bagus ya. Tapi biasanya orang-orang seperti itu kita lihat di pelantar kakinya itu pasti dia sudah ada resiko terjadi kalus ya. Kalus atau neuropati di sana, tapi dia belum muncul karena mungkin dia terdapat faktor eksternal yang mungkin dia pakai seperti sandal-sandal yang baik, terus dia untuk jalan pakai sepatu, dan dia aktivitasnya masih bagus. Dan dia hanya fokus pada neuronya. Tapi kalau jika pada iskemik itu sudah di vaskuler yang kena, dia sudah luka, dia sudah basah juga. Dan juga sudah biasanya kalau sudah iskemik dia lebih ke infeksi mengarahnya. Seperti itu. Pertanyaan yang kedua, jika pasiennya itu tiba-tiba gula darah
bisul.
Normal.
Iya, gula darah normal, tiba-tiba ada bisul tanpa sebab.
Tanpa sebab. Ini harus dicek ya vaskulernya, dicek EBPI-nya dan leukositnya. Jangan coba melakukan sendiri, meskipun kita sudah expert di bidang perawatan luka, kita coba referral sama dokter penyakit dalam. Nanti ada pemeriksaan penunjang, biasanya pasien-pasien seperti itu nanti kelama-kelamaan dia akan menghitam semua, ada eritema juga, yang lama-lama bisa menjadikan phenolic ulcer di sana. Dan itu benar-benar harus dipantau, diobservasi ya. Saya kalau penyebabnya itu tanpa sebab, tidak mungkin suatu penyakit itu bukan tanpa sebab ya. Kecuali memang yang penuh misteri saya nggak ngerti, tapi secara logika, kalau ada bisul, ada kutil dengan pasien DM itu biasanya kita sudah ada faktornya yaitu adalah vaskuler. Dicoba dirujuk ke dokter vaskuler atau BTKV yang ada di terdekatnya Bapak. Seperti itu. Timut, Mbak Sera.
Oh, sudah. Terima kasih untuk Pak Burhan jawabannya. Sudah sangat jelas sekali untuk pertanyaan dari Ibu Sari dari Kalimantan Tengah. Selanjutnya ada pertanyaan lagi dari Imakulata. Di sini mengapa setiap penderita diabetes tidak patuh pada 3 jam yang termasuk jadwal, jumlah, dan jenis mengalami komplikasi yang sangat cepat pada diabetes tipe 2. Seperti itu.
Kepatuhan dalam nutrisi atau kepatuhan dalam minum obat ini banyak sekali ya, maksudnya luas ya kepatuhan itu. Tapi biasanya kalau pasien-pasien dengan diabetes itu ada 5 pilar ya. Tapi yang saya kuasai adalah 2 pilar, yaitu 2 pilar pertama adalah kepatuhan pasien dalam exercise, kemudian kepatuhan pasien dalam manajemen nutrisi, kemudian kepatuhan dalam dia kontrol gula darahnya. Ya, ketika tiga-tiganya ini pasien itu kooperatif ya, glukosa pasti nanti akan juga normal. Dan kita juga tidak terlalu jauh dalam ingin menormalkan gula darah. Minimal 180 ke bawah, itu untuk pasien-pasien dengan diabetic foot ulcer, phenolic ulcer, ataupun yang arterial ulcer, itu kita bisa cepat untuk proses pemulihan dari wound healing-nya tadi. Seperti itu. Ada lagi, Mbak Sera?
Iya, Pak, ini masih ada lagi 2 pertanyaan lagi. Dari Bapak Agus Niru, bagaimana cara meyakinkan pasien yang sudah jelas gula darahnya sangat tinggi, tapi beliau tetap seolah-olah semua biasa saja dikarenakan sedikit pun tidak mengalami gejala yang muncul pada umumnya.
Oke. Ini memang hal lumrah ya, karena banyak juga pasien saya. Juga saya pada si pasien, Pak Burhan, saya nggak pernah mengkonsumsi nasi gula, tapi kecap sering tiap hari. Sama aja, karena kecap juga mengandung komposisi glukosa di sana. Kalau tips dan trik saya, ketika Anda berjumpa dengan pasien-pasien yang seperti ini, Anda berikan edukasi pertama. Edukasi tentang pendidikan diabetes dan komplikasinya, seperti itu. Karena ketika pasien itu melihat dari komplikasi yang sudah ada, pasien akan merasa takut di situ dan merasa semangat untuk melakukan prevention ya, promosi health ya. Sehingga dia benar-benar ingin tetap sehat seperti itu, Pak. Karena memang pasien-pasien yang di pedalaman itu yang edukasinya kurang, memang belum takut dengan apalagi belum muncul tanda dan gejala. Dan herannya lagi juga pada pasien-pasien yang di pedalaman juga, meskipun kadang sudah muncul tanda dan gejala, mereka nggak mau ke rumah sakit, kecuali sudah mulai terlihat itu objek luka, kemudian atau kalau gula darah tinggi ya, atau gula darahnya rendah, dia sudah penurunan kesadaran, dia mau ke rumah sakit. Tapi sebelum ada seperti itu, kadang mereka nggak mau. Tipsnya adalah diedukasi pasiennya secara BHSP. Jika pasiennya tidak bisa tentang edukasinya, mulai dari keluarga pasien, seperti itu.
Oh ya, jadi ini untuk poinnya, masalahnya adalah kurang pengetahuan ya Pak ya? Yang pasti kurang pengetahuan, jadi tindakan utamanya adalah edukasi tentang komplikasinya juga, dan juga proses penyakitnya. Oke, terima kasih Pak Burhan untuk pertanyaan dari Bapak Agus Niru, udah jawab sangat jelas ya dari Pak Burhan. Jadi terkait kurangnya pengetahuan ini, yang pasti yang pertama dilakukan adalah edukasi dan juga pemaparan tentang komplikasi dari diabetes mellitus jika tidak dicegah secara tepat. Selanjutnya kita masih ada pertanyaan ya Pak, sebentar saya pilihkan dulu pertanyaannya. Nah, ini ada dari Ibu Karmina Mustakima, seorang mahasiswa keperawatan dari Jakarta. Beliau menanyakan, banyak sekali saya melihat di usia 20-an sudah ada yang didiagnosa diabetes tipe 1. Sebelum makan, para pasien melakukan suntik insulin. Nah, pertanyaannya, apakah penyebab mereka terkena diagnosa diabetes tipe 1? Lalu bukankah di saat usia 20-an tersebut masih organ masih bekerja dengan baik?
Wow. Keren ya pertanyaannya. Oke, kita mengacu pada IDF ya pertama. Menurut prevalensi Internasional Diabetic Federation itu tahun 2017, Indonesia itu mengalami signifikan pada pasien-pasien diabetes itu karena pola lifestyle, ya, pola makan. Karena kalau diabetes tipe 1 itu bukan tipe dari pola makan ya, karena memang unsur genetik yang diturunkan ke keturunannya selanjutnya. Dan keturunan selanjutnya itu belum muncul tanda dan gejalanya, tapi dia pola hidupnya kurang baik dan pola makannya kurang baik sehingga dia muncul. Dan juga dari surveinya dari IDF itu Indonesia itu kurang lebih dari umur 20 tahun sudah 3,4% itu sudah terdiagnosa diabetes mellitus. Kalau kita mengacu kepada Riskesdas ya, tentang kesehatan dasar masyarakat atau mengacu dengan Kemenkes RI, itu Indonesia termasuk peringkat ke-6 dengan rata-rata dengan diagnosa dokter umur 15 tahun sudah terdiagnosa DM. Untuk manajemen seperti ini memang kita harus lakukan pengabdian masyarakat untuk pasien-pasien yang masih remaja ini terdiagnosa diabetes mellitus. Ini miris memang ya, tapi dari Kemenkes sama dari IDF dan WHO, IDF ini anak tangan dari WHO, akan diprediksi terus akan meningkat pada umur-umur dengan 15 tahun ke atas, seperti itu. Dan untuk pencegahannya itu memang harus diedukasi untuk pasien-pasien ini. Ini juga menyambung dari pertanyaan tadi yang kurang puas ya. Permasalahan yang terjadi di wilayah kami di Papua justru sulit diyakinkan adalah orang yang berpendidikan. Ini memang ini Pak ya. Memang orang-orang yang ilmunya masih masih membaca satu buku, belum membaca beberapa buku dan belum ada pembuktian, itu kadang mereka sangat meremehkan. Dan ketika sudah meremehkan, ada muncul tanda gejala, baru dia menyadari bahwasannya memang penting itu kesehatan, khususnya di diabetes mellitus seperti itu.
Jadi yang berpendidikan pun terkadang kalau pendidikannya bukan dari kesehatan, masih banyak mengelak ya Pak ya untuk kita memberikan edukasi terkait dengan kesehatan yang benar.
Kalau dari saya ya, saran saya ikuti kultur dari budaya mereka. Karena memang setiap daerah itu punya budaya masing-masing, kayak Batak, Bugis, Madura, Jawa, itu memang ada yang dikasihani, dikasih saran itu mau. Ada yang meskipun pendidikan tinggi dikasih saran itu kadang mereka, kamu siapa, pendidikanmu apa, kayak gitu. Yeah. Mereka ini coba dikolaborasikan dengan mungkin ada lurah atau penduduk setempat yang bisa jadi kayak Pak Yai, itu bisa dikolaborasikan. Atau yang di Papua itu ada Pak Lurah atau siapa yang bisa mendominasi untuk memberikan pendidikan edukasi DM pada pasien-pasien yang sudah terdiagnosa tanpa ada gejala seperti itu. Karena kalau kita mengacu di internasional dengan negara-negara yang maju, itu memang kita di screening baik-baik untuk kakinya. Sehingga untuk terciptanya pencegahannya luka kaki diabetik itu sangat-sangat menghambat seperti itu. Dan resiko dari prevalensinya sendiri itu turun. Dan kalau kita bandingkan Indonesia dengan yang lain, negara lain, memang kita rankingnya tertinggi ya. Memang kultur, budaya, pendidikan, kadang watak juga itu memang sangat mempengaruhi. Jadi kita memang harus benar-benar poinnya edukasi, budayanya dari daerah kita harus kuasai. Itu aja sih Pak.
Ya, tambahan ya Pak, yang tadi pertanyaan dari Jakarta, dari Mazal Jakarta, bahwa tentang pola hidup tadi mempengaruhi poin utama untuk pola pencetus diabetes. Nah, di sini untuk diabetes tipe 1 karena genetik, berarti kan karena banyak untuk usia tua, produktif, sampai dengan 50 tahun itu banyak yang terkena diabetes, berarti memang resiko untuk menurunkan ke generasi berikutnya itu sangat besar ya Pak ya, yang menambah dari ranking Indonesia di IGF.
Kalau dari jurnal, dari evidence based practice, dari penelitian dari orang-orang yang expert ya di bidang diabetes seperti American Diabetes Association, Diabetic Food Association di internasional, apalagi IDF, itu 70% memang untuk yang diabetes tipe 1 memang diturunkan secara genetik dengan syarat ada pola hidup yang tidak baik, kemudian pola makannya yang tidak baik, kemudian stres, itu akan mengacu produksi insulin pada pasien-pasien dengan diabetes tipe 1. Karena memang sudah gennya, DNA-nya itu sudah menyeluruh di keturunan berikutnya itu. Sehingga untuk terkena dari diabetes sendiri itu lebih cepat dibandingkan dengan diabetes tipe 2 gestasional ataupun karena treatment ya, seperti itu.
Tambahan lagi, berarti memang pola hidup sekarang tidak dapat dipungkiri bahwa banyak sekali makanan-makanan dan produk instan yang memang dibuat untuk dikonsumsi dari masyarakat, mulai dari muda hingga yang tua. Dan juga banyak sekali produk-produk yang mengandung banyak sekali glukosa. Mungkin itu yang menjadi faktor pencetus utama juga ya Pak ya?
Ya, sangat disayangkan memang ya, harus benar-benar kalau pasien-pasien diabetes foot ulcer pasien saya, itu saya utamakan ketika datang setelah perawatan, itu saya usahakan dia diet nutrisinya pertama. Ketika nutrisinya ini tidak bagus, maka nutrisi pada jaringan perifer juga tidak bagus. Ya. Yang kedua adalah glukosa. Insulin, meskipun Anda berikan insulin berapa unit, tapi nutrisinya tidak terkontrol, itu tetap, ya, insulin akan tetap meningkat. Jadi yang poin utama nutrisi sama aktivitas, itu aja.
Terima kasih Kak Bun untuk jawabannya dan diskusinya. Jadi pada intinya kalau untuk mencegah terhadap diabetes adalah bagaimana kita membatasi ataupun memilih pola hidup yang sehat. Dikarenakan banyak sekali di zaman sekarang ini hal-hal yang mengarah atau cenderung membuat pola hidup itu tidak sehat. Terima kasih. Selanjutnya kita akan melanjutkan ke sesi workshop ya Pak ya.
Ya.
Ini nanti untuk workshopnya langsung bergabung dengan Pak Rian atau gimana?
Enggak. Ini langsung pure video. Nah, untuk Rian sama Han Jen sudah live ya, karena memang mereka sudah punya kerjaan masing-masing dan kesibukan masing-masing. Karena kalau yang dari Korea sekarang sudah sore, karena yang juga di Filipina sudah siang, waktunya ada event lagi. Oke, ini bisa saya ambil alih ya Mbak Sera.
Siap.
Untuk workshopnya. Ini untuk workshopnya mungkin setengah jam, ada pressure ulcer dan lower extremitas chronic wounds. Jika nanti ada pertanyaan bisa di belakang ya. Mungkin fokus, nanti ada musik-musiknya sedikit biar nggak terlalu bosen melihat luka. Ya. Oke. Oke, apa sudah terlihat jelas nggih?
Sudah Pak.
Oh, luka pressure ulcer ya. Ini seorang perempuan ya. Di sini lokasinya di punggung. Ini sudah masuk stadium 3. Kenapa? Karena sudah masuk ke hipodermis ya. Dermis dan epidermisnya sudah habis. Kemudian dia juga wound base-nya dia slop ya, bukan nekrotik ataupun granulisasinya masih bagus juga. Kemudian untuk tipe of issue-nya dia slop saja ya. Exudatnya ini cukup banyak ya yang dikeluarkan, cukup banyak sekali, dan di sini juga ada goa ya, ataupun gap ini ya, yang di pinggir-pinggir luka, tepi lukanya tidak menyatu ya, wound edge-nya tidak menyatu. Kemudian periwound skin-nya juga abu-abu, ini masih prosesnya cukup lama ya. Ini kemudian odor ya, odor ini bau yang tidak sedap yang disebabkan oleh metabolisme bakteri ya. Yang seperti jelly ini jangan sampai ditipu oleh bakteri, ini adalah bakteri ya, yang berkerumun tapi dia belum merusak tapi dia menghambat. Ini irigasi ya, irrigation bisa menggunakan dengan irigasi untuk pencucian lukanya, ataupun bisa menggunakan ini swab ataupun hydropressure ya. Suka-suka medical doctornya atau nursingnya ya. Kemudian di sini juga ada ini wound edge tepi lukanya ini ya, tepi lukanya cukup bagus ya, tepi lukanya, tapi dia masih abu-abu, butuh asupan albumin yang banyak, bisa di putih telur ya. Kemudian ini adalah hydrocolloid powder ya. Gunanya apa? Fungsinya apa? Yaitu adalah untuk gap-gap biar menyambungkan ya, dan untuk mensupport terjadinya granulasi atau angiogenesis ya. Dan yang paling sering digunakan adalah gap ini ya, dan yang masuk di kerowongan. Oke, ini tidak ada di Indonesia, bisa impor ya, karena produk ini sangat mahal. Kemudian di sini juga bisa dipakaikan alginat ya. Alginat adalah perangsang atau support granulisasi sampai epitelisasi juga bisa. Baik menggunakan produk Kalbe atau produknya Kimia Farma ataupun Aquaceleci, Convatec ataupun Suprasol ya, Lohman Aurajan. Seperti ini ya untuk pemasangannya biar estetikanya dapat. Oke. Kemudian di sini masih di periwon skin kulit sekitar luka itu merah-merah ya. Itu di barrier ya. Di skin barrier seperti ini contohnya, bisa menggunakan topical terapi, metcovacin atau selewat garlic ya. Gunanya apa? Biar tidak terjadi luka lagi di sekitarnya dan tidak mencegah terjadinya infeksi silang ya. Bisa silang dari luar ke dalam atau yang dari luar ke dalam. Untuk kasanya bisa disesuaikan ya dengan ekonomi pasien ya, oke? Seperti ini contohnya, nanti di atasnya dikasih foam ataupun kalau ekonomis bisa dikasih. Oke guys, thanks for watching my video. Oke. Untuk video pertama sudah selesai. Kita masuk ke video yang kedua. Box kita ya, saya akan coba berkenalan dengan pasiennya dulu ya. Ini ada instrumen saya memang berikan biar ibu nggak terlalu, bapak atau ibu terlalu jijik dengan perawatan luka ini, sehingga bapak sama ibu fokus ya dalam perawatan luka kronis ini. Ini pasiennya dengan diabetes ya, kemudian ada luka di lower ekstremitas atas sinistra. Dan pasien ini sudah lama sekali juga rujukan ya dari rumah sakit tertentu. Saya tidak bisa membukanya dan kita rawat seadanya dengan modern tracing. Ini memang ditujukan untuk video ini untuk edukasi kepada para perawatnya. Oke, kita kenalan dulu sama pasiennya. Pertama, Mrs. Nyonya ya. Nyonya M di sini umurnya 47 tahun. Di sini lukanya cukup luas ya, dengan stroke dan biofilm, dan ini sudah perawatan sudah ketiganya. Mungkin Anda bisa melihatnya ya. Oke, next. Ya, wow ya, sangat keren sekali lukanya ya. Very nice. Ini adalah alginat ya. Ketika ibu sama bapak mengaplikasikan dressing ini, ketika Anda bapak sama ibu perawatan berikutnya, itu akan lebih bagus, lebih baik untuk membukanya. Ketika bapak ambil pasa ataupun yang sejenis tool, itu akan mempersulit bapak ibu ketika membuka atau perawatan berikutnya. Dan itu tidak ada support yang lebih daripada ini. Kalau alginat itu lebih baik karena memang ada hemostasis, support granulisasi, memang dan absorbennya pada eksudannya. Oke, kita lanjut. Oke, kita fokus ke lukanya dulu. Untuk lukanya ini ada granulisasinya ya. Mungkin sudah 75% granulisasi, epitelnya 25%. Wound edge-nya di sini masih setengah yang menyatu, yang lain masih belum. Kemudian odor juga masih ada. Kemudian size-nya ini 10 ini 12 kali sekitar 10-an untuk size-nya. Kemudian untuk stick-nya ini sudah stadium keempat, karena ini sudah kelihatan tendonnya. Ketika kelihatan tendon sudah masuk stadium keempat, ya. Ini sudah bengkak juga pada tangannya, ini sudah inflamasi juga ya. Ini butuh infection control. Oke, yang pertama pada saat perawatan luka adalah cleansing ya Bu ya. Bapak Ibu, cleansing atau pencucian. Pencucian tidak hanya fokus pada mencuci luka aja, tapi juga mechanical debridement juga di sana. Ya, menghilangkan tisu di sana. Tisu itu seperti bukan tisu yang dijual di Indomaret ya. Tisu, tapi tisu yang ada di wound base wound ya. Seperti ini contohnya. Tisunya apa? Biofilm, shock, ya. Ini nekrotik sudah, ini nekrotik tapi bentuknya shock ya. Ketika bapak sama ibu melakukan perawatan luka, ketika mencuci itu jangan setengah-setengah, semuanya dicuci areanya, ya. Dari luar terus ke dalam, ya, biar tidak terkontaminasi. Oke. Bersihkan area luar dulu lebih bagus, baru area dalamnya. Terserah, ketika ibu melakukan di area dalam dulu, jangan sampai ketika melakukan pencucian di daerah yang periwound skin itu masuk ke daerah dalam seperti itu. Yang penting adalah hygiene-nya ya, hygiene-nya. Semuanya dibersihkan sampai bersih, sampai nggak ada noda-noda sama bandelnya. Telapak tangan juga, di sela-sela sini tangan juga harus dibersihkan, karena di situ juga kadang ada sisa-sisa sabun masih melengket. Ya. Jika Bapak Ibu punya peralatan di rumah seperti ABBI, kayak gitu, Ibu bisa lakukan ABBI ya, untuk mengetahui adanya luka, problem di vena ataupun di arterinya. Tidak hanya di kaki aja yang terjadi, juga di tangan juga bisa terjadi ya. Ketika melakukan pencucian luka, Ibu harus benar-benar tahu mana yang swab, mana yang irigasi. Kemudian Ibu harus menerapkan protokol gentle. Ya, ini adalah protokol gentle barusan. Ketika dia membersihkan, dia langsung membersihkan di granulisasinya dengan sabun. Ya. Dengan sabun, agar apa? Biofilmnya juga ikut tercuci kayak gitu, keluar. Tapi jangan sampai terlalu menekan, karena juga posisinya pasien juga mesti nyeri ya, dan juga risiko pendarahan juga ada. Konsep gentle adalah memberikan sentuhan cleansing kepada daerah granulisasi tanpa harus membuat penekanannya seperti itu. Oke. Ini untuk pencucian lukanya, untuk cleansingnya bisa pakai apa aja, tapi recommended adalah polymethyl-hexamide, karena dia spektrumnya luas, dan untuk bakteri-bakteri yang lain itu bisa bisa dibunuh seperti itu, seperti Staphylococcus, E. coli, Pseudomonas, itu sudah ada evidence-based penelitiannya, sehingga memang aman dan fokus untuk membunuh bakteri seperti itu. Oke, untuk saat perawatan luka, Bapak Ibu itu butuh banget asisten ya, karena tanpa asisten kita melakukannya itu agak repot gitu. Terserah Bapak Ibu untuk asistennya D3 atau anak S1, terserah, sesuai dengan di klinik atau di hospitalnya Bapak Ibu. Karena ini juga menyangkut dari kebersihan dan infeksi silang ya, seperti itu. Ini yang bentuk agar-agar ini bening nih. Ini adalah biofilm ya Bu ya. Ibu pasti pernah menjumpai yang seperti ini sama Bapak ya, peserta yang mungkin di rumah sakitnya sudah melakukan, atau anak-anak yang profesi di sini ya, pasti pernah melakukannya. Jangan sampai tertipu. Ketika sudah dikeringkan, Bapak Ibu bisa lanjutkan ke nekrotomi ya. Nekrotomi Bapak Ibu bisa lakukan ketika Bapak Ibu ini stroke-nya kan sudah cair ya, sudah lunak sama sekali, Bapak Ibu bisa lakukan nekrotomi langsung. Tapi ketika nekrotominya itu stroke-nya itu keras, ada sih, saya pernah pengalaman juga, saya coba dulu, pengennya 1 hari itu selesai, tapi gunting nekrotomi saya sampai patah, karena memang nggak bisa dipaksakan, meskipun pasien tidak merasa sakit. Alangkah baiknya ya, ketika kita itu bersabar menunggu si nekrotik ini menjadi stroke yang lunak, malah lebih enak untuk untuk menekrotominya seperti itu. Ketika untuk nekrotomi takut berikan pada ahlinya ya, atau perawat yang sudah pengalaman di jam terbang untuk nekrotomi, atau perawat yang sudah tersertifikasi ya untuk perawatan luka. Karena kita kalau melakukan sesuatu tanpa ada pengetahuan, itu juga yang rugi bukan kita, tapi pasien juga yang rugi. Yang seperti itu harus benar-benar dihindari. Pelan-pelan saja Bapak Ibu ya dalam melakukan nekrotomi, tidak usah bersusul. Kalau bisa dalam 1 kali perawatan itu bisa Bapak sama Ibu itu habiskan, itu malah lebih baik untuk kondisi luka pasien nanti, sehingga granulisasinya lebih cepat dengan kontrol gula darahnya pasien. Ini adalah tendon ya Bapak Ibu ya. Tendon yang berkilau putih seperti tulang kayak gini itu bagus. Itu masih bisa kita pertahankan. Tetapi kalau sudah kusam agak kecoklatan sedikit, itu Bapak Ibu langsung rujuk aja ke rumah sakit ya. Kita tidak ambil risiko karena memang kita prosedurnya untuk privat praktis ya, untuk rujuk ya, yang bersifatnya itu sangat referral gitu. Kalau Bapak Ibu merasa bau ketika melakukan nekrotomi ini, karena kita itu di perawatan luka itu tidak boleh pakai masker. Nah, tapi sekarang sudah harus pakai maskernya. Tapi meskipun pakai masker, itu Bapak sama Ibu masih bau, ya bisa lakukan komplementer dulu ya sebelum nekrotomi, yaitu pakai ozon ataupun pakai infrared ya, dikombinasikan jadi satu untuk mengurangi dari dampak dari baunya ya. Dan ketika dampak baunya itu sudah sedikit, Bapak Ibu itu masih bisa dalam 1-2 jam melakukan nekrotomi, dan itu pengalaman saya ya. Meskipun dekat itu nggak bau, dan kita bisa melakukannya itu berjam-jam sampai habis seperti itu. Kalau nggak telaten, siapa lagi yang mau melakukan? Karena kita ya 24 jam ya ada di rumah sakitnya. Ini durasinya sekitar 45 menit ya Bu ya. Agak bersabar sedikit. Karena ini adalah ilmu pengetahuan yang sifatnya aplikatif, dan ketika Bapak sama Ibu pulang, selesai ya, dari webinar ini, Bapak Ibu bisa aplikasikan ke pasien Bapak Ibu. Nah, dari senyum mereka Ibu dapat rezeki nanti dari kesembuhan pasien. Ini adalah konsep times manajemennya, Bu, ya. Nanti juga ini adalah di D, yaitu tentang debilitas tisu, yaitu fokusnya adalah di development outcome-nya. Untuk actionnya sendiri itu bisa pakai nekrotomi ya, atau CSWD, conservative sharp bone development. Kalau punyanya dokter itu conservative sharp surgical development. Ya. Nah, dari development ini, outcome-nya adalah lukanya itu merah. Ketika kita ambil, itu sudah hilang ya. Ini sudah hilang, slope-nya sudah merah. Ya. Ketika ada perdarahan sedikit, jangan panik ya, Bu. Ya. Nanti bisa Ibu lakukan apa namanya ya, tekan ya. Tapi kalau lebih baiknya itu Bapak sama Ibu bisa melakukannya dengan alginat, karena lebih cepat untuk hemostasisnya di sana. Pada pasien-pasien dengan kanker ya, wound cancer, itu malah lebih parah dari ini. Kita utak-utak sedikit saja sudah pendarahan. Makanya kita butuh alginat di samping ketika ada perdarahan nantinya. Kalau kita tarik itu tidak masuk ke tendon, kita bisa ambil ya. Tapi kalau udah masuk ke tendon, jangan ya. Sebenarnya kalau kita cuma lihat dari video, itu gregetnya kurang. Tapi kalau kita bisa ketemu langsung luring ya, itu dampaknya luar biasa. Nah, tapi saya berharap setelah ini Bapak sama Ibu bisa mengaplikasikannya di rumah sakitnya. Ada pertanyaan, gimana sih cara membuat perawatan luka itu cepat sembuh sih? Sebenarnya modal utamanya itu adalah kita sendiri ya. Skill kita harus ditingkatkan. Manajemen kita. Ketika pengetahuan kita sama manajemen skill kita itu bagus, maka untuk hard to heal pada pasien wound itu juga sedikit dan lebih cepat untuk penyembuhan lukanya. Ketika ada stroke, apa yang harus dikerjakan? Ketika ada granulisasi, itu dressing apa yang kita kerjakan? Nah, ketika ada goa seperti itu, undermining, apa yang harus kita kerjakan? Seperti itu. Ketika perawatnya itu skillnya meningkat, edukasinya juga meningkat, maka untuk dressing itu mengikuti kita. Sama halnya dengan profesi tetangga. Ketika kewawasannya itu meningkat, maka untuk semacam obat-obatan mengikuti saja. Seperti itu Bapak Ibu. Ini sudah masuk tahap akhir ya. Sudah pengeringan, untuk nekrotominya sudah jelas. Tadi yang slok di sini banyak sekali, ini sudah habis. Yang di pinggir-pinggir sini juga sudah diambil ya. Sekarang sudah kelihatan, yang di sini tadi menggumpal, sudah red surface wound base-nya. Ini adalah gel ya. Fungsinya adalah tetap untuk melunakkan autolytic development. Itu hanya dipasang pada yang terjadi shock, ya, yang belum bisa diambil. Jangan dipaksakan pada shock yang nggak bisa kita nekrotomi. Harus dicairkan atau dilunakkan dulu. Bisa pakai autolytic treatment atau enzimatik ya. Karena ini juga sangat berperan penting di situ. Ini bukan es krim ya, tapi ini adalah zinc cream, metcopazin namanya ya. Ini adalah yang di atas Iceland Rising, tapi di sini kita harus pakai alginat dulu ya, karena dari luka tersebut granulisasinya bagus. Nah, tadi yang saya bilang, ketika skill dari perawat dan edukasinya meningkat, maka seiring waktu berjalan, pada saat perawatan luka, Bapak Ibu sudah menguasai ketika stage 1 apa yang harus dikerjakan, stadium 1, pada stadium 2 apa yang harus dikerjakan, dressingnya bagaimana. Alginat itu bentuknya hemostasis di situ, dan Bapak Ibu bisa langsung kerjakan di situ. Karena sifatnya untuk alginat ini adalah untuk peningkatan dari granulisasi tersebut. Ini adalah Iceland Rising ya, ini cukup bagus, untuk waterproofnya juga bagus, untuk absorbennya juga bagus, bisa dipakai. Tapi kalau untuk pasien-pasien yang mungkin ekonominya rendah, bisa saja langsung pakai alginat aja. Untuk cost efektifnya itu sama sih, tapi untuk absorbennya itu masih, kalau high exudat itu bisa kita tambah foam ataupun Iceland Rising di atasnya, itu masih bisa juga. Untuk masalah penutupannya di closure dressing itu tergantung suka-suka ibu dan tergantung juga kondisi dari si wound care-nya ya. Jika exudatnya banyak, Bapak Ibu bisa tambahkan fasa di atasnya. Jika exudatnya minimal, cukup pakai alginat atau foam atau Iceland Rising di atas. Dalam penutupannya, pembalutan, juga estetikanya dijaga untuk kenyamanan dari pasien sendiri ya. Karena pasien kadang juga sesuai dengan survei ya, ketika tidak nyaman itu di rumah dibuka sendiri. Dan ketika sudah di rumah dibuka, nggak ada yang ngerawat juga susah kayak gitu. Kecuali kita mau datang sendiri ke sana tempatnya. Dan ketika kita sudah buka, nanti ada nilai ekonomi seperti itu. Ini adalah the times concept ya. Bisa digunakan di tempat Bapak Ibu, di rumah sakit atau puskesmas ataupun di klinik atau di privat praktisnya ya. Semoga ketika nanti luring sudah selesai, ada seminar seperti ini, kita bisa live langsung ya, bisa ketemu langsung sama Bapak sama Ibu yang mungkin fokusnya di luka, sehingga ada nilai plus ya ketika luring itu, ketika kita mencoba untuk workshop perawatan luka yang sesungguhnya pada pasien itu gregetnya lebih dapat gitu, dan pengalamannya juga lebih dapat. Jangan sungkan juga jika butuh sesuatu, bisa tanya-tanya, bisa melalui nomor telepon ataupun FB atau melalui siapa juga bisa. Yang ada di tempatnya yang lebih expert. Ini compression ya, juga ada dua fungsi. Fungsi pertama adalah untuk memberikan perlindungan terhadap infeksi silangnya dari luar. Banyak juga sih yang pakai hanya pembalut kasa, itu masih ada belatung ketika kita lakukan perawatan selanjutnya ketika buka. Jadi memang kita butuh untuk dilakukan pendek seperti itu. Oke, Bapak Ibu, untuk workshop dengan the times concept kronik sudah selesai. Jika ada pertanyaan, monggo ditanyakan. Jika tidak ada pertanyaan, insya Allah saya akan bertanya pada Bapak Ibu. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih untuk Bapak Asmat Burhan tentang video ataupun workshopnya tentang penanganan perawatan luka secara langsung. Halo Bapak Burhan.
Ya.
Di sini sudah ada 2 pertanyaan yang masuk tentang tadi. Oh ternyata banyak. Yang pertama saya akan bacakan dulu. Ini dari Ibu Lucia Ani. Pertanyaannya, apakah alasan untuk dressing sekunder tadi mielin masih diberikan salep? Mohon penjelasannya yang setelah aplikasi Algina.
Oke. Wow, very nice question Bu Lucy ya. Bu Lucy ini lebih expert daripada saya ya, di Yogyakarta kalau nggak salah beliau ini. Kita mencoba untuk implemented dengan Iceland dressing dan melolin atau melolin ya dengan metcovacin, itu dengan harapan ketika ada cairan terabsorb, itu dengan waterproof-nya dia bisa dikeluarkan seperti itu dengan harapannya. Sehingga untuk absorbernya kan di atasnya langsung pakai kasa, sehingga dia lebih ekonomis nilainya seperti itu untuk pasien. Kalau kita bandingkan Iceland dressing dengan foam, itu mungkin ekonomisnya lebih tinggi untuk pasien, karena pasien yang ini pasien dengan BPJS seperti itu, sehingga ekonominya sangat rendah, dan kita menyiasati dengan Melolen Iceland dressing dengan harapan ketika eksudatnya banyak terabsorb dengan adanya waterproof tadi.
Oke, terima kasih untuk Pak Burhan untuk jawabannya. Jadi Melolen sendiri juga dapat dijadikan alternatif ketika memang dari segi ekonominya kurang mampu untuk memberikan dressing yang lebih mahal, seperti itu ya Pak ya. Terus juga ini selanjutnya ada pertanyaan dari Saudara Fikri Dwi Gasworo. Pertanyaannya, dressing yang tepat untuk stage kedua luka, mohon dijelaskan detail dan manfaatnya, terima kasih. Dan juga jika kita menemukan tendon berwarna kuning kehijauan, apa yang perlu kita lakukan?
Oke, coba saya analisis pertanyaannya. Pada stage kedua, apa saja yang stage 2 apa yang dikerjakan gitu ya Mbak ya?
Iya. Okay. Dressing, lebih tepatnya ke dressingnya.
Berarti kalau kita lebih lihat ke stadiumnya, kalau stadium ketiga itu sudah kelihatan tendon. Jadi kita kalau bisa itu mensupport terjadinya granulisasi di sana, sehingga tendon tadi bisa dipertahankan. Tapi kalau untuk yang step kedua itu, stage kedua itu tidak akan muncul tendon, karena pada stage kedua itu hanya di epidermisnya saja. Nah, sehingga kita perlu balutan atau dressing yang bisa mensupport epitelisasi ataupun high granulisasi di sana. Bisa pakai alginat juga bisa, aquacell itu juga bisa. Tapi di sini juga perlu dipertimbangkan untuk antimikrobial, karena pada pasien-pasien dengan luka itu juga high resiko dengan biofilm. Jadi memang dibutuhkan antimikrobial yang direkomendasikan oleh EWME, European Wound Management Association, itu antimikrobial yang bisa bertahan 3 kali 24 jam. Karena pada setiap 2-4 jam itu biofilm akan berkolonisasi, dan setiap 1 hari dia akan menyumbang lebih dari jutaan biofilm di sana. Sehingga kita butuh juga antimikrobial untuk dressing stage ketiga dan stage kedua. Apakah begitu, Mbak Sera atau yang menanya?
Jadi untuk dressingnya yang pertama menggunakan alginat dan juga antimikrobial ya Pak ya, untuk mensupport epitelisasinya. Ya. Selanjutnya tadi jika menemukan jika kita menemukan tendon berwarna kuning kehijauan, apa yang perlu kita lakukan?
Tendon dengan kuning kehijauan ya. Kita lihat dulu kondisinya. Jika warnanya itu putih seperti tulang, bening juga ya, bukan bening ya, berkilau seperti tulang itu masih bagus. Kita bisa pertahankan itu. Kalau saya pernah ke Sarawak, Hospital Sarawak di Kuching, Malaysia, itu ketika ada tendon di kaki ya, umpamanya di kaki ini, tendonnya itu masih ada, itu dipertahankan dengan cara sayatan pada granulisasi di entah itu di bawahnya yang masih utuh atau di sampingnya yang utuh. Kemudian nanti kita taburkan kolagen di sana sehingga granulisasinya cepat di sana. Sehingga apa yang kita harapkan untuk tendon itu bisa benar-benar dipertahankan seperti itu sesuai fungsinya. Tapi jika tidak ada dokter ataupun tidak ada rujukan kita atau kolaborasi, waktu itu saya di Malaysia itu ada Dr. Nizam di sana, memang spesialisnya di wound care. Dia penanggung jawabnya di sana. Tapi secara evidence based practice itu bisa, itu ada jurnalnya. Kalau mau minta tentang evidence based practice dengan pertahankan tendon dengan memberikan sayatan dan kolagen, bisa saya berikan, nanti bisa japri untuk panitia. Seperti itu. Kalau di Indonesia sendiri, saya masih sangat riskan ya, sangat takut ya, sangat ragu untuk melakukan itu, karena memang kita di Indonesia sangat riskan untuk undang-undangnya, sehingga untuk tindakan seperti ini kita perlu kolaborasi dengan dokter atau di referral dengan dokter vaskuler atau dokter internal surgeon ya boleh, atau penyakit dalam seperti itu. Suaranya Mbak Sera.
Oh iya, terima kasih Pak. Selanjutnya masih ada pertanyaan dari sudah. Iya, dari saudari Rizky Oktavia Primasari. Pertanyaannya, untuk pengerjaan luka seperti ini di rumah sakit, bagaimana manajemen waktunya? Dan juga karena pengerjaan debridemennya saja bisa membutuhkan waktu hingga lebih dari 1 jam. Saat di rumah sakit, kita juga punya banyak pasien yang membutuhkan berbagai macam tindakan juga. Sudah dapat. Jadi mungkin lebih ke manajemen waktu.
Kalau manajemen waktu, kalau untuk perawatan luka, kita tidak bisa tergesa-gesa ya. Karena sesuai survei dan eksperiensi saya dalam merawat luka, itu kita butuh setidaknya 2-3 jam dalam merawat luka, satu pasien. Dari kita asesmen, kemudian asesmennya ya di tempat saya pakai head to toe, kemudian ada asesmen luka juga. Setelah itu nanti kita rawat luka dengan komplementer, bisa berikan ozon atau infrared atau stimulasi elektrik kayak gitu. Bisa, kemudian setelah itu kita nekrotomi, itu kita butuh waktu setidaknya setengah jam ya. Dan ketika kita asesmennya itu juga mungkin waktu-waktu setengah jam. Dan pada pasien-pasien dengan nekrotiknya banyak ya, kayak tadi saya rasa sedikit ya untuk workshop. Dengan nekrotiknya yang besar atau 100%, itu kita nggak bisa cuman 30 menit. Survei membuktikan lebih kadang dari 30 menit, sehingga memang kita butuh ini sendiri, manajemen sendiri untuk perawatan luka. Karena di rumah-rumah sakit kayak Hospital Siloam, kayak rumah sakit Cibubur Amelia yang sudah memang punya poliklinik luka, itu memang satu pasien dijadwalkan setiap 2 jam. Sekali bisa referral, bisa diganti dengan pasien berikutnya. Memang ini kalau di pasien-pasien di rumah sakit, itu memang harus mematuhi protokol. Dulu sih saya pernah di rumah sakit tertentu di daerah Jawa Timur, itu memang kita rumah sakit itu mencari solusinya, mencari perawat yang memang expert di bidang luka. Jadi dia memang membayar di sana. Tapi yang saya salut di sana memang perawatan lukanya bagus, sehingga memang di cover. Untuk perawat-perawat yang di ruangan itu bisa tetap dilakukan seperti biasanya injeksi, terus swab, terus melakukan tindakan-tindakan yang lain seperti itu. Memang kita butuh satu perawat yang memang expert di bidang wound-nya atau pengalaman di bidang wound-nya ya. Karena memang manajemen perawatan luka memang butuh waktu banyak dan nggak bisa, apalagi kalau chronic wound dengan adanya pemeriksaan penunjang yang lain yang mungkin kita bisa kerjakan seperti itu. Saya rasa begitu.
Terima kasih untuk Pak Burhan jawabannya. Langsung saja ya Pak untuk pertanyaan berikutnya. Ini dari Ibu Uswatun Hasanah. Bertanya, untuk balutan luka yang basah sebaiknya diganti setiap berapa hari jika penutupannya masih menggunakan kasa saja?
Luka yang basah dengan pakai kasa gitu ya?
Iya, kasa.
Oke. Kita coba lihat teoritis proses penyembuhan luka dulu, kita jelas dulu ya Bu ya. Proses penyembuhan luka itu kita butuh ada 3 hari atau yang namanya 72 jam sesuai dengan evidence-based wound healing. Dari proses pemecahan protein, fibrinogen, angiogenesis, granulisasi sampai ke epitelisasi dengan normal gula darah dan penyakit yang lain normal, itu kita butuhnya adalah 3 kali 24 jam atau 72 jam atau 72 menit gitu. Jadi untuk pakai kasa, jika baiknya adalah, saya juga bingung ya, karena prosesnya itu juga harus 3 kali 24 jam kalau menurut teori. Tapi kalau kita mengacu ke rumah sakit, itu memang kita harus setiap hari untuk melakukan merawat luka seperti itu. Kita ini aja, kita mengikuti protokol yang ada di rumah sakit, karena memang setiap rumah sakit mempunyai SOP yang berbeda. Ketika kita melakukan dressing aja, kita juga harus mengikuti protokol yang ada, pakai dressingnya apa. Contoh Supratul atau Mebo yang bisa dipakai di rumah sakit, kita nggak bisa pakai dressing sesuka kita, kecuali kita home care ya. Setelah pasien pulang, kita lakukan bisa home care. Ketika basah, apa yang kita harus kerjakan? Ya memang kita harus buka, Bu. Ketika terlalu basah sampai tembus ya. Karena kalau kita tidak buka, di situ akan berakibat maserasi di sana. Maserasi, kemudian nanti lukanya bertambah luas, dan infeksinya juga bertambah luas. Kadang juga sesuai dengan pengalaman, luka-luka yang dengan pakai kasa itu juga bisa menambah keterlambatan penyembuhan luka, dan ketika dibuka balutan berikutnya, itu kadang granulisasi yang sudah bagus itu ikut terkikis ke atas, maksudnya ikut rusak. Karena kasa ketika ketemu jaringan itu akan nempel sekali. Jadi kita dibutuhkan adalah dressing itu yang ketika kita buka untuk perawatan berikutnya itu lebih cepat, tidak melukai luka kayak gitu. Karena jaringan granulisasi yang kita harus pertahankan seperti itu. Solusinya adalah ketika ibu pakai kasa itu harus diimpregmented, Bu. Impregmented bisa dengan topical zinc. Kalau saya rasa kalau gel itu sia-sia karena diabsorb oleh kasanya. Lebih baik pakai topical zinc cream seperti itu. Dan kalau bisa juga sesuai recommended ya, recommended dari WCET yaitu World Council-nya Wound Care itu harus 3 hari sekali. Itu solusi dari saya, Bu. Tapi kalau memang dari protokolnya rumah sakitnya seperti itu, diikuti. Itu solusi yang terbaik untuk ibu dan pasien seperti itu.
Oke, terima kasih untuk Pak Burhan jawabannya. Masih ada pertanyaan lagi, Pak? Masih bersedia untuk menjawabnya?
Monggo.
Ini ada dari Bapak. Ada dari Bapak. Sampai jam?
Kalau ada sampai jam 2, karena saya jam 2 ya. Ada kuliahnya.
Ya, terakhir ya Pak, ini pertanyaan kelima. Dari Bapak Eko Widianto. Siang Master, mohon izin bertanya, ketika kita menemukan luka abses atau bisul, namun abses tersebut masih bengkak, kaki yang terekspos tendon, ketika di pressure, keluar pus kental seperti susu, kental manis, beberapa kali kunjungan, sebentar, salah. Oh ya, beberapa kali kunjungan. Oh, saya ulangi ya Pak ya, maaf. Ke scroll. Ketika kita menemukan luka abses, namun abses tersebut masih bengkak, belum ada jalan pus untuk keluar yang bergumpal di dalamnya. Kalau diderajatkan masih derajat 1. Bagaimana manajemennya?
Berarti masih unstageable ya untuk lukanya. Nice question Pak Eko ya, Pak Eko Widianto.
Ada 2 pertanyaan dari Pak Eko.
Ada 2.
Ini yang pertama ini tadi.
Oke, yang pertama abses dengan stage 1 ya. Oke, yang stage 1 sesuai dengan pengalaman saya Pak. Dulu saya juga ada pasien dengan abses di daerah leher sini. Kita lakukan insisi. Karena ketika si pus atau absesnya itu tidak keluar, kita tidak akan pernah tahu kondisi di dalam itu seperti apa. Yang pertama kita harus keluarkan. Keluarkannya bisa menggunakan dengan autolytic debridement. Kalau memang ingin aman, kita bisa ketika ini absesnya, kita bisa pakai dressing gel ataupun dengan topical zinc cream. Ditaruh di atasnya, 3 hari kemudian kita lihat. Biasanya itu sesuai dengan pengalaman, selama 6 tahun saya di luka, itu pecah sendiri, lunak. Dan pecahnya itu secara bertahap. Ya. Mungkin kalau di surgical wound tinggal di insisi, langsung keluar, selesai. Ketika pecah, kita berikan lagi gel, masukkan ke dalam. Kalau pasiennya itu mungkin ekonomisnya ke atas, bisa diberikan dengan kolaborasi antimikrobial. Dexamethasone diimplementik masukkan ke dalam si abses tadi, sehingga sampai ketemu sticknya berapa. Kalau saya sih fokus poinnya dari analisis kasusnya Bapak ini, kalau saya sih poinnya pertama adalah absesnya dulu dihilangkan. Ketika absesnya dihilangkan, sticknya keluar. Sticknya apa? Atau wound bed preparasinya itu selama 2 minggu. Kemudian kita coba lihat yang kedua, apakah di situ ada faktor intrinsik dari si pasien tadi, glukosanya, apa vaskulernya, atau mungkin karena trauma, kayak gitu. Dulu saya sempat juga ada pasien dengan seperti itu juga abses, saya kira suspek. Ternyata saya salah, ketika saya lihat memang abses, dan pasiennya itu bisa sembuh dengan 3 bulan, 3 bulan perawatan, dan pasiennya sudah sembuh. Sehingga ketika sudah stick keduanya itu ada, sudah kelihatan bahwa Bapak bisa lakukan asesmen Bates-Jensen untuk memprediksi lukanya. 1, kapan sembuh atau progresif. Yang kedua, ketika Bates-Jensen atau asesmennya itu Bapak sudah dapat, maka manajemen untuk pengaplikasian dressing itu Bapak pasti bisa. Ketika eksudatnya banyak, apa yang harus diberikan, terus ketika ada infeksi, apa yang harus diberikan, mungkin antimikrobial atau silver, kayak gitu bisa diberikan. Seperti itu, Pak. Mungkin ada yang kedua, Mbak Sera?
Ya, Pak. Yang kedua, masih dari Bapak Eko Widianto. Untuk kasus undermining di telapak kaki yang terekspos tendon, ketika di pressure keluar pus kental seperti susu kental manis, beberapa kali kunjungan pus tersebut tidak hilang-hilang. Manajemennya sudah memakai alginat untuk undermining-nya. Mohon pencerahannya, Master.
Oh, susu kental manis ya, Pak ya?
Ya.
Memang sih banyak ya. Kadang juga ada gas gangren juga di sana. Kalau saya, solusi saya yang pertama, ketika kita lakukan 2 minggu wound bed preparasi dan hasilnya itu masih mungkin dari skala like ya 1 sampai 10 mungkin hanya stabil 5. Saya rujuk, Pak, karena memang tadi sudah kelihatan tendon nomor 1, yang kedua keluar kental ya, mungkin ada krepitasi atau ada gangguan pada vaskulernya di sana. Karena kalau saya untuk DFU dengan gejala gangren atau kalau DFU-nya mungkin hanya stage 3 atau stage 4 dengan tidak ada unsur eksudat terlalu berlebihan, itu mungkin saya bisa cover sendiri. Tapi ketika setelah 2 minggu itu belum ada progres, saya biasanya rujuk ke dokter penyakit dalam seperti itu untuk memberikan proses selanjutnya. Biasanya kalau pengalaman saya ketika ada pasien-pasien seperti itu biasanya juga penyakit dalam akan melontarkan ke ortopedi. Apakah yang terjadi? Apakah juga di situ ada osteomilitis atau ada penyakit vaskuler di sana? Sehingga untuk penata laksanaan selanjutnya itu lebih cepat dan pasien juga lebih cepat untuk meningkatkan proses kesehatannya. Jadi kalau kita itu prosesnya adalah dengan wound manajemennya, ketika ada unsur faktor intrinsik kita bisa kolaborasi dengan dokter penyakit dalam, ortopedi atau vaskuler. Seperti itu, Pak.
Terima kasih untuk Pak Bruhan, jawabannya sangat jelas dan juga langsung tepat sasaran kepada yang bertanya. Oke, untuk Pak Bruhan, sekali lagi terima kasih. Mungkin ada closing statement terkait workshop tadi.
Oke, untuk closing statement untuk perawatan luka, yang pertama adalah 1, tingkatkan skill perawat Anda dalam merawat luka. Kemudian dengan tanda plus adalah tentang wawasan Anda. Jangan sampai ya ketika ditanya oleh pasien itu Anda tidak bisa menjawab. 1. Yang kedua, ketika ditanya oleh rekan Anda, partner Anda atau dokter ya, Anda bisa menjawab sesuai dengan evidence base atau sesuai dengan ilmiah. Ketika si dokter itu bertanya dengan Anda menjawab ilmiah, maka Anda disebut partner. Ya, karena kita sudah pendidikan di Indonesia tentang perawat ini sudah maju. Saya berharap kepada teman-teman perawat di sini bisa mengupdate ilmunya dan bisa menerapkan ilmu-ilmu keperawatan, khususnya perawatan luka ini di tempat praktek masing-masing. Yang kedua, dalam melakukan manajemen perawatan luka itu kita tidak bisa only one, kita harus bentuk tim. Timnya itu yang pertama ketika merawat luka adalah asisten. Kita nggak bisa sambil mengirigasi, mencuci luka sambil gosok, itu sangat sulit dilakukan. Mungkin kalau master ya bisa ya. Tapi kalau saya itu sangat sangat beresiko untuk terjadinya infeksi silang di sana. Yang kedua, Anda bisa update untuk skillnya bisa di pelatihan, bisa, atau Anda kalau belum punya rezeki, Anda bisa magang di tempat-tempat perawat-perawat yang sudah mempunyai praktek sehingga Anda mempunyai pengalaman di bidang luka seperti itu. Yang terakhir, multidisiplin tim ya, jangan lupa karena pasien-pasien dengan diabetes foot ulcer atau diabetes itu yang terjadi luka itu kompleks ya. Jadi benar-benar harus di multidisiplin timkan atau enggak belajar tentang nutrisi, belajar tentang wound healing, belajar tentang manajemen psikologis. Waktu S1 pasti diberikan ya bagaimana manajemen ini. Itu saja dari saya. Jika ada pertanyaan atau kurang lebih atau ada yang kurang sepakat dengan jawaban saya bisa WA saya atau bisa japri saya atau WA dari panitia. Insya Allah panitia welcome kapanpun. Itu saja dari saya. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Pak Asmat Burhan untuk materi workshop dan juga workshopnya. Okay, well, this is the end of the presentations and the workshop from our speakers. Hopefully that we can get the point on it as knowledge that we got today and can increase our insights. Okay, thank you to all participants who joined this seminar. Apologize me for any shortcoming regarding the delivery or organizations of the seminar. And thanks to all speakers who took the time to share their nice expertise insight with us. Wait for another interest event from us, Permata, Hutama Kreatif, and DPD PPNI Kabupaten Tulungagung. So, I'm Sarah Aulia as moderator. It's a pleasure to host this seminar till the end and representing the entire committee. Stay safe and stay healthy wherever you are. Nice to see you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Oke, buat seluruh partisipan jangan lupa untuk pengiriman sertifikat, harap menghubungi koordinator masing-masing ya. Sertifikat kita nanti bukan e-sertifikat, jadi sertifikat fisik yang akan dikirimkan sesuai alamat yang telah dikirimkan ke koordinator masing-masing. Ada lagi pesan? Sekali lagi informasi jangan lupa untuk seluruh partisipan untuk mengisi link evaluasi akhir ya.